Salve a tutti da Roma, sono Anna Maria Vitali, benvenuti a Fascia in Movement Sport.
Herzlich willkommen zu unserem Event Faszien in Bewegung und in Sport.
Sejam bem-vindos ao nosso Fascia Movement Sport. Sejam bienvenidos todos al Fascia Movement en Deportes.
It's such a pleasure to introduce you in this unbelievable event. So welcome to all the attendees from all over the world.
This is a very nice, exciting event, a very international collaboration with some of my best friends and collaborators. Johannes Freiberg is joined with us from Brazil. In which city are you, Johannes?
Yeah, I'm fine. We have a lot of people from many countries in the South American and Latin American, like Mexico, Colombia, Chile, Argentina, Uruguay, and many cities in Brazil. We are present in this big and acute event.
And we are in contact with all the people from Europe, Asia, and so it's a very international event. So with a lot of interesting conferences. So we will have some scientific conference and some practical aspects. So what about the scientific conference, Robert?
Yeah, so I'm very excited because we were able to get every specialist that we wanted to get. We need to twist their arms because they were busy, but when they heard who else is participating and also how many organizations are working together, we got all the great presenters that we wanted to get for this topic. And this topic is not so much what happens in fascia in manual therapy, but more in movement and in sports application. So in this summit, we probably have more yoga instructors and Pilates instructors, personal trainers, and other rolfing movement teachers, dance instructors, etc., than in the previous event that you already hosted, where we had over 1,000 participants, where we had more manual therapists. So in terms of the scientific presenters, let me just the theoretical lectures today is Carla Stecco and Antonio Stecco. They don't need an introduction now. You know, it's very hard to find anybody better on the planet. And then we have from Brazil, Bernardo, who is doing something on plyometric jumping. We have Wilke from Germany on myofascial force transmission. And we have Sebastian Bohm representing Adamantios Arampatzis. And he's the only one who we couldn't get because of a family obligation that he had for today. So he recommended his collaborator, who actually did most of the research that he wanted to present. So we have from the Berlin group, we have Sebastian Bohm, and then we also have Mette Hansen talking about hormonal influence on fascia in the relationship of sports medicine. So this is a lot of information today, but we are not only sitting here as couch potatoes listening to lectures, but we also have practical.
Yes, we are going to move also, and we have very interesting practical session with 3 different presenters. From Switzerland, Karin Gurtner. From Brazil, Johannes, it's your turn. And from New York, Loris Nemetz. So half an hour for each presenter. So it's enough to keep moving, be active, and train a little bit our fascial system. So we have some other announcement.
We are thankful to the British Fascia Symposium. They gave us lots of great ideas. And one is we are doing a competition on the person who sends us the best entertaining photograph of them participating either on the theoretical lectures, pulling out their hair or whatever, or in terms of them participating in front of the TV in the practical sessions. So get your iPhone ready and send us at the end of today or also during today 1 or 2 pictures that you think are entertaining and funny and catch the exciting spirit of this event. And the winner we will announce tomorrow will receive Can you share it with us? Yes.
Wow.
The winner will receive 2 bottles, or one of the bottles of Italian wine from the people who know it best. So that is our gift for the first day.
And we will have some other prize for tomorrow. What do you think? So we can probably organize another competition for tomorrow.
For tomorrow. Okay,
Yeah.
so let me already tell you for tomorrow. There we have a gift. The title, Fascia in Movement and Sport, is very similar to the title of that handspring book. You don't see it here. That doesn't work. Let me shift here. This is very nice. I need to get my background. Right, there we go. Here you have Fascia in Sport and Movement, the handspring book, which has been translated. So I'm one of the authors, of the editors, but we have, I think, over 30 authors. It has been translated, I think, in 7 different languages. Don't ask me which language this is, whether it's Chinese or Japanese or any weird language that I don't understand on the planet. So it has become kind of the textbook on the topic of this conference. But this book finally is getting a revised edition. And let me go back here. So when the revised edition will come out, then you will get already the first copy of the revised edition, the winner of the best picture of the second day.
So now I think we are almost ready to start. What do you think?
Ready to start. Yes, I'm already excited. Fasten your seatbelts. This will be lots of new information. I don't know any field in medicine, including viral research, etc., where there has been such a rapid development. So if you attended the last Congress in Berlin with over 1,000 participants, we were very proud to be hosting that here in Germany, the last Fascia Research Congress. You will learn today that a lot of new developments have been happening. So this, one of the biggest focus of this summit here is the new information, get ready, but also the practical applications.
So, ready to start?
Let's go.
È un grande piacere introdurre, presentare.
It's a great pleasure for us to introduce Dr. Carla Stecco. Welcome, Carla. How are you? Thank you. Thank you very much for your invitation, and thank you all for taking part in this conference. Well, it's an honor for us to have you here. You are Professor of Anatomy at the University of Padua. And, well, you'll be the first speaker today, so you will open the conference, and we are all very curious and anxious to listen to your presentation. Thank you very much, Anna Maria. Well, as you can see from the title of my presentation, I will try and create a sort of common thread which hopefully will be useful for the rest of the conference, beginning with anatomy and what we currently know on the deep fascia, because I focused on that to try and understand why we have to train the fascia in a certain manner based on the knowledge that we currently have, and how the different techniques for fascial training can integrate and have different targets or goals. So I hope that my presentation will give you an idea or an overview of all of this and can also encourage further discussions. Thank you very much, Carla. This conference has a new and peculiar topic. We care deeply for movement, and this probably makes this conference unique. But now it's your turn. Thank you once again. Probably at the end we will have some questions so we can discuss the topic further. Well, of course. Excellent. So, as I just said, in my opinion, the anatomical knowledge of the fascia can become a guide to understand how to move and how to train our fascia. Because in my opinion, the different movements can affect the different aspects of the fascia. So far, we have clearly understood that the fascia is made of at least two components, one fibrous component and one loose component, and these two components respond in a different manner to load and movement. As a consequence, we have to be aware of how or what these elements are and how they answer to different movements in order to train them in a consistent and rational manner. But let's start with the first component, the fibrous component. If we look at the fascia lata as the iliotibial tract, we can see that bundles of connective tissue are found in the lateral region of the thigh. These bundles of connective tissue are crucial to coordinate the knee and the hip in order to transmit load along the lower limb and support us when we stand. In this case, the direction of the collagen fibers and the perfect arrangement of collagen fibers play an important role in this force transmission. If we take even a small section of fascia and we stretch it, we can see bundles of collagen fibers that are arranged in the direction of our traction, and they play a major role in tensioning the fascia and in transmitting a certain tension at a distance, working similarly to a tendon. Speaking about the fibrous component, I would like to show you some studies that we carried out a few years ago together with the engineering department at the University of Padua. In particular, we studied the plantar fascia and the crural fascia, but I'll start with the plantar fascia because it's easier to understand, meaning that most collagen fibers are arranged longitudinally. Because the plantar fascia is strongly longitudinally oriented in order to transmit the forces from the forefoot to the back foot, as we can see in this image. So we can neglect the transverse or diagonal component that we find in other fascia and test only the longitudinal component. And that is why we took samples of fascia from different individuals and we isolated fragments of fascia a half centimeter wide, a few centimeters long, and we tested them according to the main direction of the collagen fibers. The equipment that we used is this system manufactured by Bose, which makes it possible to record any deformation of the fascia based on mechanical forces that we provide in an absolutely controlled manner. This allowed us to understand how the fibrous component respond to different mechanical inputs. this is the image of our fascia and how it is stretched. So we kept a 1 centimeter distance between one clamp and the other, and as you can see, the fascia can be tensioned in a uniaxial direction. The limitation of this test is that it has been performed at an ambient temperature of 20 degrees, so not a physiological temperature, which is 37 degrees. This can be a limitation, and in the future I'd like to repeat this test using a controlled or physiological temperature. This is the first result that we achieved. It's the preconditioning test. So we took the section of fascia and we applied a mechanical input which lasted 1 second. Then we released and we applied a second input and released again. So in a regular manner, there is a mechanical stretch every second. We checked how the fascia responded and which kind of resistance it provided to this stretching. We have seen that if we take 100 as the first response that we got from the fascia, the second time the fascia registered a lower peak, meaning that its resistance decreased. The third time a little less, the fourth time a little less, the fifth time a little less, until up to the seventh time when we reached a plateau, after which the tension, the resistance of the fascia no longer changed. This means that the fascia needs some cycles, say 6 to 7 cycles in order to warm up and probably arrange the collagen fibers within the fascia. But once these fibers are aligned, are arranged according to the direction of the force we are applying, it no longer changes. So we can say, clinically speaking, that a warm-up can have a role also in the fascia because it allows the fascia to reach a new balance. So it has a less stress response, but this is not something that happens gradually or increases gradually as we move. The fascia rather achieves a new balance rather quickly, after which its mechanical response stays the same. The second study instead tried and determined whether the fascia is able to return to go back to its initial state, or if once it has been stretched, it changes permanently. So we performed a series of stretching motion to 4 to 8% of fascial elongation. We waited a few minutes and we repeated the stretching, recording exactly how the fascia deforms as we stretch it. We have seen that if we leave a few minutes to the fascia goes back exactly to its initial state. And the second time that we stretch the fascia, it will follow exactly the same path that it followed the first time. This means that the fascia is not a plastic tissue. It does not deform, but rather tends to behave exactly in the same manner any time that we propose the same movement. What does this mean, clinically speaking? Well, it means that if we stimulate the fascia, if we perform exercises, we cannot expect a sudden change in the fascia because the fascia has its own motor memory, so to say. So it tends to go back exactly to its initial state, and the next time it will follow exactly the same deformation, the same evolution of the first time, of the first movement. So we can use the fascia as if it were a tendon, meaning that every time it behaves in the same manner and transmits the forces in the same manner. It does not change anytime there's a muscle contraction. But in movement, this means that it is not that easy to modify a fascial structure. I would like to show you the stress-strain curve. The stress-strain curve, in my opinion, is extremely important. We were the first in Padua to develop the stress-strain curve for fascia, which already exists for muscles, bones, and tendons. It indicates how the fascia changes based on elongation. And it also tells us how much the fascia is able to resist elongation before tearing. Up to 4% elongation, approximately, the fascia has a non-linear behavior. So the fascia, we stretch the fascia, and the fascia, based on that stretching, reaches 4-5% elongation, after which there is a linear phase, meaning that the fascia transmits all the force that we are providing at a distance, as if it were a rope or a tendon. It no longer deforms, but acts as a transmission element. Above 12-15%, as you can see, the curve starts to collapse, because this type of elongation indicates a progressive damage of the fascial tissue and the collagen fibers. And then, above 20%, the fascia is permanently damaged and is no longer able to resist tension forces. From an histological viewpoint, we can look at this sequence where a fascia completely at rest with no tension whatsoever has undulated collagen fibers. So, as I said, there is no tension. But if we start to stretch the fascia or pull the fascia, the collagen fibers gradually follow the direction of the force, but they still do not resist to tension because they have still an undulated pattern, but then gradually they become straighter and straighter. So in this case, they transmit forces at a distance because there is no adaptation capacity within the fascia, which just transmits the force at a distance. And then we have the first tears in the collagen fibers, just a few at the beginning, then they gradually increase up to the total destruction of the fascial tissue. This is a sequence which matches well the curve I've just showed you. But that curve is all the more significant if we compare it with the curve of the tendon. This is a traditional curve of the Achilles tendon. We can see that the shape of the curve is quite similar, but the percentages change, meaning that the tendon has an adaptation phase, so to speak, up to 2% approximately. Then it starts its linear phase up to 4%, after which there is rupture or tear. So the tendon withstands less elongation and has a lower adaptation capacity. But tendons are there specifically to transmit forces at a distance, muscle forces to the bone, so it does not need to have any adaptation capacity, whereas the fascia needs to have adaptation capacity because enveloping the muscles, it has to be able to allow for a change in the shape of the muscle during contraction. If it didn't have this adaptation capacity, we would always have compartment syndromes. So the fascia has this more complex anatomy because it has to be able to transmit forces at a distance and at the same time to adapt to muscle contraction. But if we look at the curve of the muscles, we see some impressive data. As you can see, these are the same curves of several muscles. Up to 40-50% elongation, these muscles give no resistance whatsoever. So when we say that during stretching a muscle is short, well, that's a mistake, because the muscle could elongate at least up to 50% of its value without giving any resistance. It's the connective tissue around the fascia which is limiting that movement, which is creating resistance. So the hamstrings are stiff, and it's the fascia which is stiff, and it gives this feeling or sensation, whereas the muscle per se wouldn't give any resistance. The bone is completely different. It has a linear phase at T0 and then a phase of rupture at 0.4%, meaning that it is not able at all to adapt to deformation or strain. What can we say? What can we add? Well, the fascia can act like a tendon, transmitting forces at a distance, especially between 4 to 10% elongation. So it needs to be partly tensioned. But this initial tensioning that we have seen up to 4% probably in a living person does not exist. So the fascia is always under basal tension because there are muscle insertions and the fascia is tensioned or is affected by the tone of the muscle underneath. So it's constantly tensioned by the muscle underneath. So the fascia, in my opinion, is always at the beginning of its linear phase. But what is interesting to us is the rupture or tearing phase, because I believe that many muscle sprains, well, in those cases, we need to understand whether it is fascial, whether there is a fascial or muscular component. In some cases, for example, in sprains, there is obviously a muscle sprain, but probably also the fascia is involved because becoming stiffer before the muscle, it needs to heal to allow for muscle sprain. So in the healing process, we need to understand how to treat the fascial tissue which was damaged. Another experiment that we did, which was very interesting to me, is the hysteresis curve. The hysteresis curve is a curve that, in my opinion, should be at the basis of any training of any athlete, because it tells us how much energy we dissipate to perform a certain movement and how much energy we are able to return as elastic energy by stretching the fascia. So we created a curve just as the stress strain curve, but then we have also left before or stopped before a rupture, and we kept on recording how the fascia returns to its point zero. So we have already said that the fascia is able to go back to its initial state, but how? If the fascia were a perfect elastic tissue, it would go back exactly on the same line. But as you can see, in none of the tests that we made, the fascia went back to the same line. This means that we wasted energy as it, because this is linked to the viscosity of the tissue that, in order to go back, consumes in friction a small amount of energy and turns it into heat. What does this mean? It means that the area between the loading and unloading curve is the area, the hysteresis area, so the area that we are using as viscous elements or heat and so on and so forth, whereas the area below the curve is the area or the energy that we can return as elastic energy. Just to give you an example, when we serve in volleyball, we stretch the anterior fascia, and to perform this movement we are using energy, we are activating muscles. Once we have reached maximum tension, we release and we contract anterior muscles and the fascia itself, to go back to its initial state, returns energy, which adds to the energy of the muscle contraction that we are activating. The more elastic the fascia is, the more efficient it will be when returning elastic energy. So it will add to the muscle energy that we are using. This is, in my opinion, a key point in training, because we have clearly seen that often athletes who are very powerful are not necessarily muscular or huge, but probably they have an optimal hysteresis curve in their fascia. Or let's take runners, for example. So far, we have always considered the length of their tendons, because we know that they are able to store energy and to return it as elastic energy, but the fascia is like a huge tendon that goes to the tip of the foot up to the fingers of the hand of the other side, of the opposite side. So it's able to store really a huge amount of energy and return it as elastic energy. This study assessed the response of the fascia to static stretching, essentially, because we have taken our fascia, we stretched it, and then we left it there under tension, under stress, and we tried and assessed how the fascial tension changes when we leave it there stressed. As you can see, within 20 seconds, its intrinsic tension decreases by 30%. If we leave it there, after 1 minute, there is a 40% decrease. But then we left it there 2, 3, 4 minutes, and it didn't decrease any longer. This means that the fascia, under tension, under stress, if this is constant, it gradually decreases its internal tension. So it relaxes, so to speak. This happens in a very efficient manner in the first 20-30 seconds. Then we gain something in a minute, but positions that are kept for longer does not seem to affect significantly the fascia. This is a test that has been done on a cadaver, so a non-living person. On a living person, we should consider the relaxation effects, mental effects that can be provoked by positions kept for a longer period of time. But from a mechanical standpoint, we reach the best effect after the first 30-40 seconds, but beyond that, there is no real significance. So this is what I just discussed. Very briefly, I would like to show you also the part of the crural fascia, because we repeated the same tests, the same studies, but as you can see in this image, the complicated aspect of the crural fascia is that the fibers go in different directions. So they have a multi-directional arrangement, so it's not easy to understand how to stretch the fascial tissue. We decided to stretch it in a transverse and longitudinal direction to see whether the response of the fascia was different. Generally speaking, we have seen exactly the same things that I just said when it came to the plantar fascia, but I wanted to show you this curve, which is the beginning of the stress-strain curve, because it suggests that the fascia or the crural fascia has a strong anisotropy. What does this mean? It means that it responds differently depending on the direction of the forces at play. So if we stretch the fascia in a longitudinal direction, we have this curve. So the fascia quickly goes towards the straight line, meaning that it is stiffer. Whereas if we stretch the fascia transversally, the curve is lower, meaning that the fascia is more adaptable, it's more elastic. from a clinical standpoint, this is very important because the longitudinal direction, or in a longitudinal direction, the fascia, especially the lower limbs, needs to coordinate the ankle with the knee, with the hip. It has to transmit muscle forces, as we can see in this image of the sartorius. So it's crucial that it becomes stiff quickly. Otherwise, it wouldn't work as a transmission element. Whereas in the transverse direction, the fascia needs to be adaptable, because anytime we contract a muscle, the muscle widens. So the fascia that envelops it needs to allow for this change. If it were too stiff, it wouldn't be able to do it. So this adaptability is made possible by the loose connective tissue, which is between one bundle of collagen fibers and the other. So it allows the collagen fibers to be to maintain a certain distance. So there is adaptability in one direction, whereas adaptability in the other. So as you can see, the fascia is, mechanically speaking, a very complex tissue to understand and train. But what can we see in a living person? Well, so far we have made a series of considerations, starting a part of fascia taken from a cadaver. But we need to assess tissues that have an active biological activity. It has been estimated that the turnover of the collagen fibers in humans is about 300 to 500 days. In my opinion, this is plausible information because it matches what happens during our training. We cannot change our fascial structure in just 2 weeks of training, even intense training, because training is within this physiological turnover, trying to guide this turnover in the direction that we wish. So the repeated mechanical input within this physiological turnover will lead to fascial remodeling of the fibrous component based on our goals. But we need to have long-term targets or goals. We need to plan a 1-year training at least. Sometimes we can have changes after 6 months, but we cannot expect very quick changes. The other element that we have to consider is that collagen turnover depends on a constant balance between the activity of the fibroblasts that produce collagen fibers and release them in the matrix, and how active the collagenase is. Collagenase is an enzyme that degrades the collagen that we produce. So in this balance, the fibroblasts produce new collagen, collagenase degrade old collagen, so we gradually recreate new fascial tissue. Carla and Siciliani, more than 20 years ago, showed that the stretching of fibroblasts could increase the turnover by increasing the secretion of collagenase. So fibroblasts become more active, produce more collagen fibers and more collagenase, so there is a quicker turnover. So stretching as mechanical elongation of the fibroblast, so any load that we put on the fibroblast quickens the turnover. This has been demonstrated also by Professor Langevin. But the negative aspect is that fibroblasts become or tend to adapt to new situations, to new conditions. So if we give a certain load, after 10-15 minutes, they reach a new balance, and so they decrease their metabolic activity. So it's important also to give a varied input in order to maintain them active, because they tend, as I said, to adapt quite easily to the new condition or to new mechanical inputs. Another interesting thing is that Troubled in 2003 demonstrated that lactate is able to stimulate the synthesis of collagen. This can have a negative effect on our fascial tissue, especially in the intramuscular fascial structure, because an excessive buildup of collagen could lead to fascial fibrosis, and the muscle tissue becomes stiffer. This is a study carried out by Slimani that showed the effect of immobilization. So if we do not move a certain part, the connective component changes, and especially type 1 collagen within the muscle, especially in the perimysium. So in a normal, healthy tissue, the perimysium is a thin line which gives no specific resistance, but after 1 month of immobilization, the connective tissue becomes thicker. This creates stiffness at the level of the muscle, but we also have all the muscle spindles which normally have to be activated in order to allow for muscle contraction. In a perimysium of this type, minimum mechanical tensions are enough to stimulate a muscle spindle, but at this level we could think of the muscle spindle as no longer able to activate. Diabetes can also affect collagen fibers because there are a number of studies on the plantar fascia that showed that in diabetic patients there is a change in the synthesis of collagen fibers, especially type 1 collagen decreases, which is the one that is mechanically strong and transmits forces, with an increase of type 3 and type 4 collagen fibers. So the fascia in the plantar fascia in diabetic patients is thicker and mechanically less efficient. So the studies were carried out only on the plantar fascia, but I believe that other fascial tissues could be affected in the body. So we maybe should take this aspect into account when we have to treat or train patients suffering from type 1 diabetes. Recently, we have carried out a study on hormones or the hormonal component. We studied the role of estrogens in our fascia. Here you can see a few images of an experiment that we carried out stimulating the cells taken by the fascia with different levels of estrogens, simulating postmenopausal, follicular, periovulatory and pregnancy phases. The colored elements are collagen fibers produced by the fibroblasts. As you can see in the postmenopausal levels, the fibroblast does not produce collagen fibers, so we have reduced fascial metabolism. In the periovulatory and pregnancy phase, the fibroblasts are very active and produce loads of new collagen fibers, stimulating fascial remodeling. But we have also tried and understand what kind of collagen fibers are produced. And here we have looked at type 1 collagen. So surprisingly enough, we have seen that in the periovulatory phase and in the pregnancy phase, type 1 collagen is not produced, whereas there is a production of type 3 collagen and fibrillin, meaning the elastic fibers. What does this mean? It means that the fascia in a pregnant woman or of a woman in the periovulatory phase is more elastic, more adaptable as compared to the fascia in other periods of the cycle. So on the one hand, this allows for the adaptation of the abdominal wall to the fetus, Obviously, we need to change the shape of our abdomen, but at the same time, it leads to a certain loss of stability, which is linked to the fascial component, because a fascia, which is stiffer with more type 1 collagen, can help stability at the level of the SI joint or the lumbar spine, whereas when we lose this component, we could have lumbar low back pain, pelvic pain, which are very common in pregnant women, but also in certain periods of the menstrual cycle. This study is quite in line with a study that has been published quite recently, where the researchers assessed the fascia with different methods, using also a stabilometry platform, and they confirmed that in the ovulatory phase women have a higher fascial elasticity, but this leads to a reduction in balance or a decrease in balance. So they suggested that we have to consider that certain exercises, depending on the phases of the cycle, might be more appropriate. Also, when the same considerations apply when it comes to trauma. So this stability, the sensitivity of the fascia to estrogens changes a lot. In the studies that we have carried out, we have showed and demonstrated that in postmenopausal women, the number of receptors expressed for estrogens is reduced. So it's not just a matter of how many estrogens there are, but also the sensitivity of the fascia to these estrogens. And the number, as we said, the number of receptors decreased. In this study, we demonstrated, or it was demonstrated, how the fascia is affected by hormone levels, and also the tendons are affected. As you can see, there is higher laxity in the ovulatory phase, for example in the knee, which is related to a change in the structure at the level of the anterior cruciate. So if you train women's team, you know that most traumas of the knees are more frequent in the ovulatory phase, because there is, as we said, a certain loss of stability. Unfortunately, age has a negative effect on the fascia. This is a study carried out by Trindade on the temporal fascia. The researcher created a stress-strain curve and saw that in 20-year-old people, the fascia is way more elastic as compared to 50-year-old people. This is a study that we did, where we assessed how the connective tissue changes in a young person, or in a 18-year-old person, in a 32-year-old adult, and in an elderly person. These are the muscle fibers, and this is the collagen component. As you can see, in the 18-year-old individual, there is muscle with minimal collagen. In the 32-year-old individual, there is a slight decrease, increase of collagen fibers. In the elderly, there are many atrophic fibers, and the collagen fibers fill all the spaces left by muscle fibers. What does this mean? Well, it means that the muscles are stiffer and stiffer, so we have less force or strength in the muscle fibers, which is more and less effective, but I also have to contrast an extracellular matrix, which is increasingly stiffer and more difficult to move. But now let's move to the last part of the presentation, the loose connective tissue. We have said that this is the second component of the fascia, which allows for the gliding of the fascial planes, the sliding or gliding of two different muscles. Here, this is a leg. We can see that the gliding of the deep and the superficial components, which is made possible by the possibility of the fascial planes to glide one on top of the other. This loose component is composed or made of water, ions, and glycosaminoglycans. My group has been focusing a lot on the glycosaminoglycans, and we reached a conclusion. This is essentially hyaluronic acid. So we can analyze in depth the factors that influence the viscosity of hyaluronic acid, because if we have water and hyaluronic acid binds water and transforms this water from a liquid solution into a jelly solution, which is similar to the sanitizing gel we have all become very familiar with. This gel can be more or less viscous. If it's watery, it creates no friction, but the more viscous it becomes, the more it creates friction between fascial planes. And we have seen earlier that in the hysteresis curve how this friction alters the possibility of the fascia to work properly. So we want to have hyaluronic acid, which is fluid, which is liquid. From an analysis or a review of the literature, we are trying now to repeat these tests in my lab, how hyaluronic acid is affected by temperature. In particular, a difference of 2 degrees is enough to significantly change the viscosity of hyaluronic acid. The colder the environment, the more viscous is hyaluronic acid, whereas it becomes fluid when the environment is warm. On a practical step point, this matches exactly what we feel when we move. So if we move in a warm environment, we move more easily. In a cold environment, we are stiffer. Many techniques try specifically to warm up the body to perform the movement better. Or we, for example, let's think on how many times we feel stuck because we have spent too much time in the cold, or we feel a stiff neck, a stiff back, and we use the hot water bottle and similar devices because we are working. And we improve the situation specifically because we are working on viscosity. Then there is the effect of pH on hyaluronic acid. This is one of the curves that I found on hyaluronic acid, and this is the physiological range within which our body normally is. As you can see, it's at the beginning of this long plateau. This means that the viscosity of hyaluronic acid does not change with the alkalinization of our pH, whereas it changes quickly if we go towards acidosis. But we have seen that at muscular level, we can easily, after intense exercise, reach a value of pH which is 6.6. This kind of value corresponds to a 20% increase in viscosity, approximately, which is a significant increase because it means that there is more friction in our fascia and the fascia becomes stiffer or stiff. This could be one element that can explain certain stiffness after exercise that we feel, and then as we try to bring the pH back to physiological values, and we get rid of hyaluronic or hyaluronal buildups, we feel better. Finally, we know that movement itself leads to an increased production of hyaluronic acid. This is important also from a functional standpoint because when we move, if we move, this movement stimulates the production of hyaluronic acid to facilitate movement precisely. But if it increases too much and if it builds up and we have hyaluronan buildups, this becomes more, or alluronan becomes more viscous. So something which initially is correct because it facilitates sliding, if it becomes excessive, and if because of pH and other factors starts to build up, then it makes the fascia more viscous and hence stiffer. This can be another factor that explains fascial stiffness. And finally, we have to bear in mind that alluronan is a thixotropic substance. So if it binds, creating a viscous solution. If we shake it just a little, these bonds, which are very weak, break and the substance becomes more fluid. So normally I use the analogy with ketchup. If you leave the ketchup for a long time on the table, it will not come out. If you shake it just a little, it will come out quite easily because ketchup is a thixotropic substance just as alluronan. So we need to move it just a little to make it more fluid. And this is what our patients do, although they are unaware of it. They say that when they wake up, they feel stiff, but then they start moving, they take a warm shower, and then they are well for the rest of the day because they work on the two elements that modify alluronan, meaning movement, which can be a movement in any direction, because we need to break these bounds, and warm water that works on temperature. So to conclude, we can say that when we train or when we think of our fascial tissues, we have to consider whether our target is the fibrous component or the loose connective tissue. The loose connective tissue, as we have seen, respond to temperature, pH, hydration, because obviously it's mostly water, to movement, and this movement needs to be multidirectional because the forces at play are extremely weak. So training the loose component could be quite easy because any movement could be appropriate as long as it is done in a multi-directional and varied manner. Whereas when we think of the fibrous component, well, things get more complicated because we need to guide physiological remodeling, which already exists in our fascial tissues, but based or according to the target that we have set. So we need to understand what our target is, what kind of fascia we want to have, what lines of force we want to use. So normally, this type of training needs specific directions, specific organizations, coordination between different segments. It needs load. So I think that we should study or investigate more these aspects to understand what is the best manner to train our fascia. Thank you very much, Carla. A really wonderful presentation, and you explained the points and topics that we were hoping you would present, because you spoke about the complexity of the fascial system. And I have a question, or a comment rather than a question. Since there is so much complexity, we need to plan a training that cannot be easy, but it has to follow, to respect this complexity. So my comment is, or my consideration is, that the studies that we have to carry out going forward need to consider the type of training that we have to plan, and the complexity for a trainer can become also a challenge. So sometimes we avoid this complexity by using protocols. So I just wanted to know whether you share my remark, my comment, and what you think about the need of reviewing certain training plans. Well, Anna Maria, normally I'm against the concept of protocol by definition, meaning that I believe that each and every one of us is unique, has their own trauma history, postural history, emotional background. The interpreter apologizes, but the audio is not good at this time, so we are not able to translate. Well, I believe that protocol is good for a healthy person, a person who has no particular problems, so we can use standard training. But when we are dealing with a person who has had traumas, we need to, and we want to reach a specific target, we need to understand very well the body we are dealing with to train it properly. So it's obviously difficult. A training that is well done is obviously difficult. We cannot just give the patient a training sheet. We need to study the person. We need to understand their body. And we have to study movement and the training consequently. We have to decide whether we want to stimulate the loose connective tissue, or if we want to strengthen certain myofascial connections, if we want to improve motor function, proprioception. Well, we have to work according to the target that we want to achieve. The interpreter apologizes again, but the sound is not good enough for us to translate. So, as I said, we need to understand what goal, what target we want to achieve, and then work accordingly. So we can say that the message that we can get from your presentation is that in the future it will be all the more necessary to customize training, taking into account physiological conditions, different in age, hormonal levels, different phases of life, and make or target the training to the person we are dealing with in order also to prevent injury. So is this correct? Yes, of course. Just wanted to add something. If we have a person with low back pain, there is tension in the thoracolumbar fascia. We can be a direct injury of the thoracolumbar fascia, but also there are associated pain in the neck, in the back, in the limbs, and these patients need a different management. So if we have this anatomical knowledge, the knowledge of continuity, we can understand how to treat the patient better in a personalized or customized manner. Thank you very much once again. Carla, thank you, Anna Maria, for organizing everything. See you next time.
Thank you, Professor Antonio, to come with us. And Professor Antonio Stecco is a PhD and graduate in medicine and surgery
and is specialized in physical medicine and rehabilitation of the University of Padua. And he has been doing many researches that include the application for hyaluronic acid and myofascial syndromes and pains and other things. Stecco was recently elected the assistant president in the International Society of Physical Medicine and Rehabilitation. So thank you, Professor Antonio Stecco, for accepting to come us with as a part of this Team Fascia movement and sport project. So what you're presenting for us today? What you are coming for a presentation for us today?
Well, today we are going to present a research that we have done about fascia and sport injury prevention, because sport injury prevention is a very important topic. We still don't know what are the factors that increase the incidence of injury. So we understand now that the fascia is a key role for biomechanics. So an incorrect fascia system, a dysfunction in the fascia system, can increase the number of injury. So we have proved with this study that we are going to present that if we assess the fascia before the season, you can have a better season with more performance and less injury.
That's wonderful. Okay, see if you are already. We are already here too. It's okay.
Okay, so
you can share. Yes.
Okay, so this lecture it was done with a collaboration of different group. So the title is Sport Injury Prevention in Individual with Chronic Ankle Instability. So chronic instability, or let's say ankle problem, is the most frequent alteration that we will see in the majority of the sport, or is the high incidence injury in sport. If we take a look, soccer player, football player, they have a high rate of ankle sprain. Like say 61% of the soccer player has before or after an ankle sprain. In 19% of these people, they start to have more than one distortion ankle sprain. So it starts to become a very chronic issue. So normally when we talk about ankle sprain, we have to looking for, okay, where exactly is the problem, okay? We don't know exactly what ankle sprain is affecting. We know about the ligament, but there is a lot of article that doesn't explain that the ligament is related with the dysfunction that the patient has, because normally your ankle is more rigid, it's not more lax, more flexible than before. So it's not a question of so much about ligament. On the top of that, we know that in any case, this problem can be very, very affecting the performance. And we just know that in Netherlands, for instance, they spend 43 million a year just to try to improve the outcome of ankle sprain. So the outcome of ankle sprain is what we call chronic ankle instability. That is a dysfunction where basically you have an alteration of the capacity to stabilize the ankle to perform. So this time we don't have a best treatment. We don't have a gold standard, because if we take a look on the literature, you will see that we have a review in 2007 that said the manual therapy, proprioception, weight bearing, exercise should be included after chronic ankle instability. But at the same time, 2013, we have another review that said the manual therapy cannot be recommended in the treatment of acute ankle sprain. So should we add or should we add not manual therapy? So this is not clear. And on top of that, they say only that what is really works is proprioception, balance board, ankle disc, so exercise. This obviously is basically, let's say, time consuming for the participant, so for the patient, because we know that the compliance for exercise has to be really strict. Is primary importance the effectiveness of the intervention. So we normally, or it's normally prescribed 20-30 minutes, 3 times repetition weekly or daily for 9 weeks. So you can imagine this doesn't fit the request of short recovery that the athletes need. So this guideline that we have right now for ankle instability do not fit with sport athletes, but even day live activity. You cannot wait 9 weeks before to go back as before. So this forced us to find out a new way to try to restore, improve, fix the chronic ankle instability. So we did a study. We studied a semi-professional soccer team. We tried to evaluate this guy at the beginning of the season, 1 month, 3 months, 6 months, and even at 12 months. So at the end of the season, we try to evaluate with the typical FMM, so the functional ankle and foot questionnaire. We try to have a patient that have at the least 1 week prognosis, like a previous, I mean, at the least like a ankle problem, okay, already chronic, okay, and we try to exclude the people that have a previous important fracture, neurological problem, okay, or other therapy that they were undergoing that period. So we basically divide the group in 2 groups. One group got only exercise, so under 20 minutes, divided in 45 minutes, running, 50 minutes with kicking, jumping, exercise using freedom table, in other 25 minutes of muscle stretching. At the top of that, we have a second group that did the same, but at the top of that, we add 3 sessions of fascial manipulation. That is a manual therapy that works in specific spot to decrease the stiffness of the fascia. So basically, this is the flow chart. So we have the recruitment randomization. We have the study group with the 3 sessions of fascial manipulation and the follow-up. The control group with the only exercise and follow-up. And then a basal line, so subjects, they have no symptom at all. So with all the tests that we did, with all the questionnaire, they have a full rate. So it means that they have no minor deficit at all. That was the group that was like a group for control. So the foot and ankle ability measurement scale allow us to understand how this guy do with normal activity and with sport activity. And then we evaluate the range of motion, active, passive, active resistance, and we try to evaluate all this kind of detail. Then we add also a stability platform evaluation. We did it simple. We did with the Nintendo Wi-Fi that is still a validated method to assess the stability of one patient. So we recruited 81 patients. We excluded 52 because they have they didn't fit in the criteria of inclusion. 9 subjects was perfect without any type of symptom limitation, but 20 were symptomatic and were able to fit in our criteria of inclusion. So we divide, randomize in 2 groups, and we follow up the student, the participant, the athletes until the end. So as you can see, the scale, the score of the scale was quite similar. The sport was pretty similar, one and the other. The number of ankle sprain was basically the same between the two groups. So the two groups was homogeneous. What's very interesting that at time 0, both ones start with 75 score when 84 is the maximal. At the first, at 1 month follow-up, so after 3 sessions of fascial manipulation, we already see a statistical significant difference between control and study. At 3 months, we don't reach the statistical significant difference because the exercise have improved a little bit, also the other group. But then in all the other tests, all the other follow-up, to 3 to 4 to 5, so like 12, 6, 9, 12 months follow-up, you see that there is always a statistical significant difference. And the subject that they were treated, they get close to 84, that is the maximal value that they can have. So what do I mean? That with the 3 session, 3 treatment of fascial manipulation of 45 minutes each, so a little bit more than an hour and a half, you can improve for all the season the performance of the athletes. It is very, very, very important because it means that you can improve the capacity of the athletes, starting with a simple 3 treatment at the beginning of the season. But what is very, very, very interesting for us that we check the ankle sprain during the season, or like the injury that the guy had. And here was even more impressive difference, because at T1, we have 1 severe injury in the control group. So 1 subject over 10, he had to stop the season due to the major injury. At T4, we have 1 subject that had to stop 6 days for a minor injury. At T5, I have another subject that had to stop for a severe injury. And at T6, okay, they have 2 kind of severe injury. They were at the end of the season, so they decide to stop the season because it was almost done. But you can see that this study group didn't have any major injury at all. So this was, we were lucky for sure, but this was a giant difference between the study and the control group. So all this data are published. You can find out Brandolini et al. 2018. You can see all the detail of this study. So if you take a look in the passive dorsiflexion, you see that there is a statistical significant difference, and we were able to get even above the reference, even above the control group that were asymptomatic. In the left ankle, again, even the control group, they improve with exercise over time. But the one that have fascial manipulation improve much more, and they get over the reference, over the control group. The group that have no symptom at all, and so they were like the group that have a reference. About the stability, so the stability platform didn't give us so excellent result at all. We have few data that were statistically significant difference, but many other that were not. This is why, because it's a double fit evaluation. So obviously the good fit will carry on the instability of the other ankle. So for this reason, we didn't have like a major statistically significant difference between control and study group, but some data were better. So in this trial, like 50%, half of the subject, they get like a minor or major ankle sprain during the season. Some they didn't have the control group, the study group in this case. They wanted to have a fascial manipulation. What is the secret? Because even the journals say, what is the secret? Why did this happen? Because we treat the full leg, and we went to treat even the opposite side. because you don't have to stay local. You have to restore the full biomechanics. So how Conders explain that the sequela of a traumatic event can expand up to contralateral side. So with FM, we treat the full leg, the pelvic region, the lumbar region, so to restore completely the biomechanics. It is the secret to allow the subject to have a perfect performance, perfect biomechanics, and avoid injury even later on. If you don't work globally, you will not have this kind of result. And this is why we have such a impressive result. This I can tell you. So remember, everything time after time generate compensation. And the compensation will get to contralateral side as well. So these are all areas that you have to work to try to restore the biomechanics. So the first conclusion of this presentation is that for sure, we don't have a double blind because with manual therapy is not possible, but we explain that with FM, with fascia manipulation, we can restore range of motion, improve performance, and decrease the injuries during the season. So what I mean this one? We focus a lot of attention, not just in the fascia, but in particular in the retinacular. The retinacular of the ankle, as you see right here, is a layer, okay, is a multiple layer that you will see at the level of the inferior ankle, superior ankle area. So we have basically mostly like two retinacula in the ankle, the inferior extensor retinacle of the ankle and the superior extensor retinacle of the ankle. Here you see the inferior. You see this is a major tear that happened after ankle sprain. But over time, this lesion will resolve and the retinacle will become thicker and stiffer than before. This will happen in few months. What is the problem? This is what happened exactly as with the ligament. You tear the ligament repair, become thicker. But if it becomes thicker, it becomes stiffer. So it means that you have a stiff ankle, but the retinacle is well innervated. So from here, instead to have a proprioception, you can have pain. This is the reason why you have an alteration of the proprioception, why you start to have a functional ankle instability. Because when the retinacle becomes stiff, the retinacle is not able to give you the correct proprioception of the body. So you have a lack of proprioception, and this will generate a lack of coordination as well. So we have a couple more information. So it's important for us to differentiate what is a retinacle, what is a ligament. So remember, a ligament, all the collagen fiber go in one direction. A retinacle go in multiple directions. A ligament is very poor innervated. A retinacle is very well innervated. So both one can be tear, but the retinacula, it will generate a sequela, will generate like a decrease of proprioception, a decrease of the coordination. So the ligament will not generate. So look, retinaculus, everybody draw in a different way, but it's a reinforcement of the deep fascia, okay? So everybody try to isolate the retinaculum, but in reality it's a reinforcement of the deep fascia. So it's very important to understand that there is a continuity, but this is so rigid part that when you have an ankle sprain, you can tear. And this tear, it will make a healing process, it will make this area more stiff. So separate the retinacula is incorrect. So you have to see the continuity of the fascia. You have to understand that just this reinforcement is where there's more low transmission. So retinacula is the key element for proprioception, but the fascia, the deep fascia, is the organ for proprioception. We always say that the retinacula is the most innervated part of the fascia system, more of the deep fascia, let's say, more appropriate. So if you have an alteration in this area, you will affect a lot the way that you perceive the motion in the ankle. So the retinacula have connection with the muscle, like extensor digitoris brevis, with the other tendon, okay, with the tendon sheath, with the bone, okay, with the periosteum. So retinacula have a lot of connection. At the same time, I have a different layer. I have 3 layers like at the deep fascia: longitudinal, transversal, oblique. So the retinacula is able to glide it to follow the motion of the ankle. It's not elastic at all. It's very rigid. But at the same time, it's very well innervated. So the retinacular, whenever you stretch the retinacular, you generate a huge afference that can generate proprioception. But if it's too much afference or incorrect afference, it can generate pain. So when you have a functional ankle instability, it means that the rehabilitation is the target. It's not surgical. So you have to really understand where is the problem to organize a correct treatment plan. So we did a study, another study published in 2010, and we saw that in 25 subjects with chronic ankle instability, 14 have alteration only of the retinacula, and only 7 have alteration of the ligament of the bone or edema of the bone. So really, retinacula is the element that can generate a functional ankle instability. In fact, is it clear in literature that there is a sensory motor change, but nobody understood so far where is the change. Is central the problem? Is peripheral? So they did a few studies. They understand that it's not the laxity that generates instability, but is an alteration of the feed-forward process that send message to the ankle and go back to the brain. So there is something periphery that generates the problem. It's for sure is not the hyperlaxity. So they tried to anesthetize the ligament to see if anesthetic in the ligament will affect the proprioception, but it didn't change at all. At the opposite, if you anesthetize all the foot, you have the deficit of proprioception. So it means that in the foot, there is the proprioception organ, but it's not the ligament. So again, also this study will support the idea that the retinacula can be the peripheral structure that will work for proprioception. So again, when we are talking about chronic ankle sprain, always think about that the retinacula can become stiff. It can become the structure that will affect, it will perpetuate the chronic ankle instability. So in order to restore that, you have to understand fascia anatomy, fascial physiology, pathology, and also treat properly, restoring the gliding and restore what we call densification. So the rigidity of the fascia will affect the way that the receptor will be activated. So fascia manipulation have proved that we can do that. We can do that for a short term, but also for a long-term efficacy. So we really recommend to assess the athletes at the beginning of the season, because through a correct assessment, through a correct evaluation, you can really understand what is wrong, even if there is no symptom at that time. But that assessment will restore the biomechanics. It will give a much better quality of performance to the athletes. Thanks a lot.
So it's amazing, because I'm very, very interested in this, because you know the sports people didn't know too much about the fascia in the training. If, in your opinion, or in your day of life, have you been working with the sports athletes in your clinical? And I saw that you have working with them in the many recommendations for the athlete. But in your day of life, did you receive some sports practitioners, and what your recommendation for that? For example, prepare yourself every day with some kind of stretching. It could be interesting for prevent the retinacular, the instability, or the coordination, because of course one part is understand that how we do intervention, but for example, when the gym, is there anything that we can do in our practical day of life just to begin to start to prevent this? What do you think about this? Because I know you are a runner, no? And how you prepare yourself for your runner, for example?
Well, I mean, we have a lot of collaboration. We have formally trained a lot of soccer players like Juventus, Napoli. So we were there, we trained all the medical team. In US, we train all the medical team, all the team of New York Mets, Diamond Blacks, Los Angeles Dodgers. We were there with the Padres, with the national. So we train all the medical team. And now they start to understand that prevention is possible, because through a correct assessment, palpation of the body, you can understand how is the biomechanics. So if you have athletes, in particular athletes that have not direct injury, like tennis player, baseball player, so that athletes, they have a clear overuse, they have a repetitive pattern, they don't have direct trauma, direct injury. So that athletes are the best one where you can predict how the season will go, because you know exactly how they are at time zero at the beginning of the season, and you will see that from there they just increase the overuse, the stiffness in the tissue. So that are the best target for you. So these athletes are really golfer player, so upper limb without direct injury, are really volleyball player as well, are really the athletes that you can really think about. You can guarantee, look, this guy will do much better because I assess him, I find out this and that, I treat this and that, he will be better. I will not be confident to say the same. I mean, soccer player, we did a good job, but it's risky because they can have a direct contact with someone else. You never know. Okay, or American football as well. I will never say, look, I will do prevention in this subject. But specific to sport where you have not contact, not with the other athletes, not direct injury, you can clearly do that. And if there was no COVID in September, we should have started to do preseason evaluation in US. So one team, they invite us, all our group, to go there, screen all the athletes of the first league, check it out, treat, and see how it goes. It's a really important investment. So, I mean, imagine
I agree.
to have like a 30 million pitcher that suddenly is not able to play because start to have a pain. Like before the most important game, there is a lot of stress. There is a lot of training. And suddenly they say, look, they go, suddenly they start to have headaches, neck pain, shoulder problem for the stress. It is crazy for me, my opinion, to try to treat in emergency situation, like on side of the field, try to treat to fix this guy. It's much better to do at the beginning of the season or at the end of the season, when you are quiet, you have the time to reset the body, because when you do that, you reset the weight you pitch. You can increase the strength, but at the same time, you change a little bit. So even for the athletes, it's better to have this approach at the beginning or the end of the season, when they can reset the body. They feel that they are able to move more with different power. And you are more safe because you are in a safety time of the season. So if you know what you are doing, you can clearly do out of season, even out of pain. It's definitely more convenient, more safe. You have a better player and you don't waste money, because if you have a player that is not able to play, you lose $1 million over this player. So do that during the season. It's okay, but it should not be the rule, should not be the standard, that you just take care of the patient when he's in such pain, because before everybody's afraid to put the hand over because they don't know what to do. You know what to do. you know the anatomy, you know the physiology, you can put a hand in a player of 30 million, even if it has symptom, because you can just improve the performance. You're not going to mess up the way you play.
I agree. Okay, thank you very, very, very much, Antonio. You clarify many things about the fascia and how retinacular could be very important for us, you know, to know our perception movement, because the fascia, it's very important in our daily life. You know, in the sports movement, it's precisely, this is very, very important. Thank you very much, Antonio, again.
And let me remember everybody that retinacula is not just in the ankle. We have retinacula in the patella, in the knee. We have retinacula in the wrist, in the elbow. So we have a lot of retinacula. So you have retinacula is the key element of the fascial system. Well, we have retinacula in different districts of the body. So you can approach this concept in all the districts. So for all the sport.
Perfect. Perfect. Yes, I agree. Thank you very much. And to stay with us again in this team of fashion and movement in sports. And I hope you stay your day nice today, and a happy life for you too. Thank you.
Thank you. Thank you, everybody.
Bye.
Bye.
Hi, Karin. How are you?
Excellent. Hello, Anna Maria.
So you be the first teacher teaching the practical section. So it's up to you to start the practical section. We will have 30 minutes. Is that true?
That is perfect. And I'm very honored. Thank you.
Oh, yes. It's a pleasure for us having you in this incredible event. So this class is for everyone. Everyone can do that.
Everyone can join, and it's for, you know, for the practice movers and also those who want to engage in a different kind of movement. The important thing is own the class, make it yours, adapt as you need to feel really good with the movement. So it's not a strict protocol, it's an invitation.
Yes. Is there any contraindication? Problem, for example, in joint and back, something like that?
Yeah. So again, it's an invitation. We will do supine movements, and I will show exercises with different loading. Always, to those who join me, choose the degree of load that is right for your body, especially when it comes to the lower back. We want resilience, but looking at it from a fascial perspective, it takes time. So give yourself time. Yeah. There is a whole sequence of kneeling exercises, which can be quite challenging in the beginning. So here's what I suggest. If it feels challenging, see if you can still do them, but use cushioning, really good cushioning to make it softer on the knees. If that's not yet working, you can do the exercises in standing. That works well. And you can also do them in sitting. You just need to decrease the range of movement. But what I really suggest is keep practicing in sitting or standing, and then try again on the knees, because they are, seems counterintuitive, really, really good to unload the knees. But again, it might take a few weeks or a couple of months of small doses of regular practice.
So perfect. So what do we need for this class?
You need a mat and 2 soft massage balls and something for beneath the knees is really helpful. And that's it.
So, ready to start. See you in 2 minutes.
Haha. So just one word, Anna-Maria, hang on. Just one word for the runners amongst you, or the swimmers, or the weight training people. Maybe right now, because of our global situation, you can't go out and do your preferred movements. Still join me. Like, these exercises prepare myofascially, sustain the conditions in your body to engage in your preferred outdoor activity. So while you are confined maybe to your living room, you can still prepare for when you can go out and run and swim and weight train. So open your mind, join me on the mat. I think it will pay off right now and in a few months. Thank you.
Perfect. Thank you, Karin.
Thank you very much.
Thank you for joining me in this Slings myofascial training lesson, a movement practice that I consider resource-oriented and integrative. Today's focus is on creating the neuromyofascial skeletal conditions for ease and efficiency in walking, running, and other athletic activities that benefit from proprioceptive finesse and fascial elasticity. It is a progressive class. We will start on the floor with exercises that have many benefits in their own rights, and also prepare for the more dynamic exercises in kneeling, weight bearing, and standing. All you need beside a mat are 2 softish massage balls and, if you like, a kneeling pad. You can start in supine with the massage balls beneath the pelvis. Position the props in a way that you can center your pelvis with the least amount of muscular effort. We are aiming for a centered alignment in the pelvis and the lower back, meaning your lumbar spine has its natural extension. The legs are about hip distance apart, with the heels in a comfortable distance away from the pelvis. Keep the feet where they are and press them lightly away from the body, and then release the pressure. As you press the feet away from the body, let the pelvis tilt back and the lumbar spine flex. And then release the pressure, center the pelvis and the spine. To enhance the pelvic tilt and lumbar flexion, engage your pelvic floor and abdominal muscles deliberately. Not strongly, but perceptibly. focus on the connection of your pelvic floor to the rectus abdominis. You can envision a tensile strap that spans from the tailbone to the pubic bone and from the pubic bone to the sternum. Of course, the oblique abdominals and transverse abdominis also assist the movement. In fact, it is an inside-out activation. The hip extensors, keep them as uninvolved as possible. While you're pressing the feet away to initiate the pelvic tilt and then assist the movement with a light activity of your pelvic floor and abdominal muscles, you are promoting glide in the fascial layers of your lower back. And glide is a key for movement ease and fluid flow, which then assures a speedier recovery, for example, after intense activities. You're also promoting tensile strength. As you tilt the pelvis back, flex the lumbar spine, you tension the different layers of the thoracolumbar fascia and, of course, all other fascial structures along your spine as well. And with that, promote fascial strength in your back very gently. And you're preparing for a more dynamic exercise that's about to come. Keep the pelvis centered, the lower back centered. Keep the light activity in your pelvic floor and abdominal muscles, and then float one leg into a tabletop position, knee above the hip, and then float the foot back down, change side. You are engaging the muscles within your pelvis and around the spine as much as necessary and as little as possible. We are aiming for dynamic stability, not fixation, meaning you're hovering on the edge of instability. The pelvis remains stable, but still it is not fixed. This is a brilliant movement for core stabilization, and it's also preparation for the kneeling and weight-bearing exercises we're going to do. Now, in terms of myofascial collaboration, we have a deliberate neuromuscular activity here to stabilize the pelvis and the lower back. The muscular force is transferred to the spine via the fascia. All of your abdominal muscles are fascially continuous with the different layers of the thoracolumbar fascia. In that sense, the thoracolumbar fascia acts as a force transmitter that dynamically stabilizes the spine. The next time one leg is in tabletop, preferably the second leg, you lift it, stay there, engage your pelvic floor and abdominals more strongly, float the second leg into tabletop. If you like, connect the legs and then draw the knees towards the chest. Now, minimal muscular activity is, is the purpose here. Let your heels drop down and then move the knees above the hips. Move the knees towards you and bounce. Knees above the hips. And again, you let the knees fall towards you and bounce. The aim is to utilize fascial glide and tensile strength in your thoracolumbar fascia, and with the rhythmical movement also promote elasticity. Fascia is a slow renewal system. Collagen architecture changes slowly, so we are aiming to develop crimp that makes fascia more resilient. And it takes a few weeks and months. So count on 9 to 12 months if you haven't done any of these dynamic movements before to really, like, you'll feel change as you go, but to really create that fascial architecture that enables you to move dynamically without injuring yourself. So if you want to stay with this for a while, or you start to add more longer lever, so more load. This can be just a lifting of the lower legs, or after a while, you might feel comfortable extending the legs. So you have a really long lever now. And then when you feel comfortable, resilient, springy with this movement, you might want to flex your feet. So you add even more tension to the fascia in the back of the legs and also in your lower back. Let's do this one more time. And then you can keep the knees bent, move the knees above the pelvis, step one foot down, step the other foot down. Press the feet away, tilt the pelvis back, lift the pelvis off the balls, remove the props from beneath your pelvis, roll down. Center the pelvis and the spine, float one leg into tabletop, second leg into tabletop, if you like, connect the legs, take your arms up towards the ceiling, curl up, hold on behind the knees, and then press the legs into your hands, roll up, cross the legs, roll over the knees, and move into a 4-point kneeling position. If you like to use a kneeling pad, place it beneath your knees, and then you can also place the balls to the front of the mat. Establish a centered alignment in your pelvis and your spine in 4-point kneeling. Connect your tailbone to the pubic bone, your pubic bone to the sternum, curl into cat. Press your hands away from the body like you press the feet away from the body, angry cat. And now you can make a choice. You can either do very small movements here, like so, or you can lift your hands off the floor and make the bouncing movements bigger. Your pelvic floor and abdominal muscles remain isometrically engaged, strongly. Your hip extensors, they are engaged a little bit. Don't make it as little as possible, otherwise you might feel strain in your knees. Now, while your upper body, especially around the lumbar pelvic area, is muscularly supported in the position, you let the quadriceps fascia elastically lengthen and recoil like a spring. And this is a wonderful exercise in its own right, and it's a great preparation for the next series of movements. Next time you're on your way back, take a seat on your heels, center the upper body, raise your arms overhead with an arm arc, active forward fold, arm circle back, tilt the pelvis back, curl up into high kneeling, open the arms. I will mirror you. Move your right foot out, lift the right knee, and walk the right foot forward into a 90-90 kneeling position. Raise your arms overhead, and then press the foot forward, fold forward, place your hands onto the floor on either side of the foot, and shift forward and backward. When you shift forward, keep the heel on the floor. When you shift back, keep the toes on the floor. The knee can go further forward than the toes. However, for now, it stays in line with the base of the second toe. This is a glide promoting exercise. Promoting glide at the moment, this is our intention here across the front of the ankle. And because it is a glide promoting exercise and we do it slowly, we use a full range of movement, which is different to what we will do in the dynamic exercises. Let's go forward one more time. Take a ball, shift back, glide forward and lift up into upright 90-90 kneeling. And then place the ball behind the front knee. You might want to step a little closer. Center the upper body. Dynamically stabilize from within. You shift the weight forward, and we're going into a dynamic shift. The ball behind the knee does several things. So A, it is at the moment limiting the range of movement. decreasing the knee flexion and dorsiflexion. And when we do dynamic exercises, we stay out of end range. So this is an absolutely wonderful proprioceptive tool, the ball, to do so. The ball also provides a massage, it provides a stimulus on the hamstrings and the gastrocnemius, and where it's pressing into the myofascia of the gastrocnemius, there's also a pressure point that facilitates fluid flow to the foot. Let's do this one more time. Stay lifted. You might want to stay with the ball again for a few weeks, maybe even for a few months, see how you feel. When you feel you've got a rhythm that is good for your body, you feel comfortable with that controlled fall, you can remove the ball and use the pressure of the foot as an initiator to move you back up. You let the weight shift forward, and then before you're at end range, you press the foot away and you initiate the recoil. So we are giving this elastic movement a little bit of a muscular impulse to initiate the recoil. This is excellent for developing proprioceptive finesse, and it can make the movement springier, especially at the beginning, and not jarring on the joints. Last one. Stay lifted. Again, if you want to stay with the pressing away of the foot, please do so, or you can let the weight transfer forward, elastically tension the fascia and let it recoil you. It's a smooth movement. There are no edges, so there is spring and buoyancy in it. Our focus is on the Achilles tendon and the quadriceps fascia. Is it really the Achilles tendon? Maybe part of it, more the proximal part, and maybe it's more of the muscular fascia of the gastrocnemius, and that's great too. And now you can stay lifted and make a choice. Either you're walking out slowly to the 90-90 gate pose, or you do it dynamically, turning the foot out and then turning the foot in, or more accurately, you're turning the hip joint out and you're turning the hip joint in until you're in a 90-90 gate pose. You can stay the way you are. I will turn toward you so you can see the movement more easily. Glide into a hip release and go to your end range, just for proprioceptive information. If you're very limber, lift up higher. If you're more on the stable side, you can stay lower. Either way, you're not at end range. Lift from the pubic bone, find that pelvic floor abdominal connection. Press the heel and the knee toward one another. Feel the activity in your adductor muscles. Sustain it. Hold. Lift a little higher. Release and recoil. And let's do a few dynamic hip releases, utilizing the elastic capacity of the adductor fascia. In sports and also in walking, the elasticity in the iliotibial band is really important. However, what we have found in practice, the elasticity and also the tensile strength of the adductor fascia makes a big difference, not just for movement, but also for dynamic stabilization in the pelvis. Sacroiliac joints also, or especially, not also. I mean, it's in the pelvis. And now you can turn the knee down, bring the foot back. I will join your direction again. Place your hand to the front of the pelvis, sit back, centered, tilt the pelvis back, curl up. A centered alignment, and then moving into a segmental movement of the spine. So it's a muscularly coordinated action here in which the fascia acts as a force transmitter. And in the lower body, we are promoting glide within the quadriceps muscles and around them, and also around the iliotibial band, which is incredibly important to have happy knees when you are doing more athletic activities. Let's do this one more time. And then stay lifted, change side. Take the left foot out, lift the left knee up, walk forward. 90-90 kneeling. Raise your arms overhead. Press the foot forward, fold forward. Hands on either side of the foot into the shift. So once again, you use your full range of movement. And with full range, I'm aiming to plantar flex and dorsiflex the ankle fully, extend the knee as far as comfortable, flex it as far as comfortable, and also in the foot have the longitudinal arches open and lift, so moving toward pronation and supination. In terms of glide, we are aiming for glide around the retinaculum, and the retinaculum is a highly proprioceptive structure that informs the rest of the body what is going on in the foot. Take a ball, glide forward and lift. You can place the ball behind the knee again, center, move the foot a little closer if you like, and then bounce. So little bouncing movements with an abundance of benefits. And one that I haven't mentioned before, that's really key to eventually utilize inner elasticity, because right now it's the elasticity of the ball mainly that is bouncing you back up, is rhythm. The ball is a wonderful tool to develop rhythmicality in movement, and movement rhythm makes a big difference with which efficiency you utilize the elastic capacity of your fascia. Stay lifted. If you like, keep the ball. If you like, remove the ball, and use that little muscular initiation for the return. Controlled fall. And before you're at end range, you push the foot away. So everybody has a different fascial rhythm, and it is important to find yours. And you will notice in time, it will actually change. So in the beginning, there is a certain rhythm, might be speedier, might be slower. And then as you utilize the elastic capacity of fascia more and more efficiently, rhythms change. So stay really tuned into your body to feel the rhythms that make you feel buoyant and springy rather than laboring through an exercise. If you like to leave the pushing of the foot, it is a controlled fall followed by a recoil, a movement that requires very little active muscle contribution once you have practiced it. We want to give fascia time to develop a resilient architecture, to develop crimp. Therefore, whenever it comes to elasticity, I think it's worthwhile to create the conditions: glide, tensile strength, fluid flow, and proprioceptive finesse to then safely and effectively go into the dynamic elasticizing exercises. Stay lifted, make a choice, slow or dynamic transition, taking the leg out into a 90-90 gate pose. I love the dynamic transition. It gives different lines of tension onto the involved fascial structures, and it makes us more adaptable, and especially in sport, we can't always control the angles, depending on what sport you play. I will turn toward you. So you want to be fascially resilient at all angles, chosen or not. Glide into the hip release, go to your end range for exploration. Lift a little or lift more, depending on your movability. Lift from the pubic bone, draw the heel, the knee toward one another, engage your adductors in length, and you might get a Titan response here, which eventually will lengthen your muscles, yet keep the strength. So you have athletic or athleticism in your muscles, but you still have the length, so not the bulk that is developed when shortening muscles or training in a short position. Lift a little higher, release and lift. And let's do a few dynamic movements to shift from the muscular strengthening, which we did before in the static position, to fascial-focused elasticizing in this dynamic movement. And once again, you find a rhythm that is suitable for your body. Pelvic floor abdominals, steadily engaged. Movement in the lower body. And then turn the knee down to the floor. I'm turning your way again. Establish a high kneeling position. Place your hands to the front of the hips. Lift the sternum. We are adding a movement to the sit back and curl up. So long extension, sit back centered, and then curl up. And roll straight into a long extension, lifting the myofascia in the front. Sit back, curl up, promoting fascial glide and tensile strength in the front of your body. And as you roll up, promote glide and tensile strength in the back and the thighs. Last time. And now you can sit back into low kneeling, fold forward into a child's pose. Take your arms overhead, curl up into a cat position, center the pelvis and the spine, tuck your toes under, shift the upper body back, lift the knees, extend the legs, dynamic double knee bend, followed by an easeful leg extension. You can stay in this rhythmical movement like so, that's great, or you can add a hop on the spot. Landing softly, hopping up, utilizing the elastic capacity in your legs and giving it a bit of a muscle-empowered upward movement. So if you're hopping, you can float forward, otherwise walk forward, and then curl. Moving from a very active, sympathetically driven motion into a parasympathetic-oriented pose. Extend the legs as far as comfortable, forward fold leg stretch. Re-engage pelvic floor and abdominals, start to roll up. And let your spine extensors elongate your spine with minimal muscular effort, until you are standing in an upright position with your head balanced on top of the spine. Raise your arms forward and upward. Lift the sternum, reach out from your arms, and then swing the arms back, let the spine follow. The arms lead. The spine follows. Opening the front of the body, creating length, fascial tension, glide, and also a little bit of elasticity on the return. And now we're adding the back of the body. Bend the knees, swing back. Dynamic double knee bend, long extension. As you swing back, you curl the spine. So you're utilizing elasticity through the whole body, from the feet, up the legs, across the back of the pelvis, the spine, and then in the front, from the hips, up the front of the body. One more time. Stay lifted, lower your arms, raise your arms overhead one more time. One slow arch, and then center the body, and I do hope you feel invigorated and fascially empowered.
Hi, Professor Bernardo. Welcome to the Fascia and Movement in Sports, this great event about physical activity. How are you?
I'm fine. How are you doing, Johannes?
I'm fine, thanks, too. So let me introduce you, Professor Bernardo. Professor Bernardo is a PhD in biodynamic of the human movement. In the Unicamp, he's a cute university in Brazil, in the state of Campinas, and he is a physical education, and he emphasizes his studies in the sports training. His PhD and post-PhD is in health science. So, Professor Bernardo, what you are bringing to us?
Hello, Johannes. Yeah, my research line is about strength and power in sports, and recently we are performing very interesting studies about fascia. This line of research that I know about with you. Thank you very much for introducing this research line. I'm learning a lot. Thank you very much. And in our lab, sometimes we are investigating the phenomena of post-activation potentiation. This is a phenomenon very interesting and is well consolidated with strength training inducing the post-activation potentiation. Basically, resistance exercise, high intensity, low volume, long rest intervals, inducing the post-activation potentiation. But nowadays, we are trying to investigate if the fascia, if the manipulation of the tissue may induce the same phenomena induced by resistance exercise. So we are performing some very interesting experiments that I would like to present here in the event. Okay?
Thank you.
Can I share the PowerPoint?
Yeah, please.
Let's do it. All right, so I have some main topics here about the fascia and potentiation. Basically, we use the vertical jumps as a tool to observe the phenomena of the post-activation potentiation. And the vertical jumps, they were performed on a force plate. It's a very interesting instrument used in research, but the parameters, they are not so easy to interpret. So I'm going to explain some parameters obtained from the force plate. And afterwards, I'm going to present the fascia manipulation and acute counter movement jump performance changes. That is basically what we are trying to study at this moment, okay? So what is post-activation potentiation? For those who never been introduced to this concept, post-activation potentiation refers to an acute enhancement of muscle performance. It happens in the results of the contractile history. It is considered the basis of complex training. So what is complex training? It's a kind of training method used for elite athletes. So the post-activation potentiation effects, it has some influences on force production. It may increase peak force, rate of force development, power. It's basically used in elite athletes, strength and power modalities. Post-activation potentiation may be induced by myosin light chain phosphorylation. So if everybody now is recording some basic physiology classes, they will remember myosin light chains phosphorylation. The joint characteristics, the joint kinematics, joint velocity. It also may increase range of motion. Post-activation potentiation may be induced also by motor unit activation. So remembering some basic neuromuscular physiology classes, the motor unit activation, the pennation angle, muscle stiffness, and also may increase the reactive strength. Okay, so basically this is the phenomena of the post-activation potentiation. I bring here some examples of how we can basically apply complex training in sports. So we have here 5 examples of training protocol sessions, basically. They are called strength power potentiation complexes. Here we have the performance activity that is going to be potentiated. For example, the 40-meter sprint, horizontal plyometric jumps, vertical jumps. And here we have what we call as a conditioning activity. So here they basically use a heavy resistance exercise like the heavy loaded squats, 3 repetitions, 90% of 1 RPM. It's very heavy exercise. A little bit recovery time for basically phosphocreatine recovery. And then afterwards, the activity is performed. Another example is use of Olympic liftings, weight liftings like power clean. 3 repetitions, 90% of 1 RPM is also very heavy exercise. The power clean is characterized as a high force exercise and high velocity exercise. Another example of squat protocol, 5 repetitions, 30% 1 RPM, 4 repetitions, 50%, 3 repetitions, 70%. And that's all. We have a lot of examples of strength power potentiation complexes structures. As I told you, the post-activation potentiation, this is a very well consolidated phenomenon in strength training literature. And we are trying to investigate now if we can replace all of this heavy resistance exercise by fascia manipulation. That's what I'm going to show you in a few moments, okay? So here we have one meta-analysis where they are presenting basically the effect size and a lot of interesting activities that may be potentiated, like, for example, jumps performance, horizontal and vertical jumps performance. So post-activation potentiation is a phenomenon that has a great ability to enhance jump performance. Sprint performances as well, throwing, and upper body ballistic exercise. So the phenomena is very well consolidated in the literature and basically induced by heavy resistance exercise or plyometric exercise or Olympic weightlifting exercise, okay? Well, to conclude the post-activation potentiation phenomena, I'm bringing here some factors that may modulate this phenomena and affect the performance of subsequent activities, power activities. Condition intensity, condition volume, the condition type, if we are going to perform dynamic muscle actions, isometric muscle actions. This is very important. The subject's characteristics, the muscle strength. Weaker individuals, they do not present post-activation potentiation. The fiber type distribution. Individuals with less type 2 fiber types, they also has less post-activation potentiation responses. Training levels, individuals has to be highly trained. The strength power ratio and other physiological mechanisms like the myosin, light chain phosphorylation, the motor unit recruitment, and mechanisms of basically fatigue. Recovery time is important as well. And everything, all of these parameters, they may be manipulated to induce the performance increases, okay? Subjects maybe is the most important of all of them, okay? Well, one tool to observe the post-activation potentiation phenomena is basically assessing the vertical jumps. So here I'm bringing 3 examples of vertical jumps that are frequently used, observed and studied in strength and power literature. Basically, the squat jump is a very simple jump where the subject here, in this case, it's me, was a little bit younger over here. And I'm here in a squat position. My hips are flexed, so I'm standing over here for a few seconds to eliminate the counter movement effect, to eliminate any stress shortening cycle presence over here. And then afterwards, I'm going to jump. So this is a very example of the basically squat jump assessment. It's a vertical jump assessment used in sports science, okay? The other jump is the counter movement jump. This is the most popular of the vertical jumps. The counter movement jump, here I am again. I will start in the standing position. Afterwards, I'm going to put my hands on the hip. It can be performed with the hands on the hip or with the free arms. It depends on what you want to observe, okay? So here I'm going to put my hands on the hip, flex my knees, my hip, and then afterwards jump again. Usually the counter movement jump has a higher jump performance than the squat jump. And the other classical jump observed in literature is the drop jump, where the individual is going to be placed over here in a higher platform and will fall. So the acceleration due to gravity will make me fall, and then afterwards I'm going to react and jump over again. Okay, so this is the example. Here we have the examples of the three classical jumps observed in literature. They are frequently used as measurement tools to observe performance enhancement induced by the post-activation potentiation phenomenon, okay? Basically, we are going to analyze the counter movement jump performances, so I'm coming the attention from everybody about this kind of jump, okay? Well, vertical jumps, they are largely depending on factors as maximal force capacity, rate of force development, muscle power, impulse, muscle activation, muscle coordination, and basically they are reflecting our stress shortening cycle use. Basically, the counter movement jump is the most popular among all the vertical jumps, okay? So that's why literature considers the counter movement jump as one of the most used tests for monitoring neuromuscular status in individuals and team sports, as well as in the military training, okay? It is also used as a marker of fatigue and supercompensation. We are going to use the counter movement jump to observe the phenomena of the post-activation potentiation, okay? Another basic concept for the understanding the data that I'm going to present is the force plate. The force plate is this device that is used in sports science, lots of research. We can see the force plate on the materials and methods of the articles. It basically works with the third Newton law, okay? So we are basically analyzing the ground reaction force. So when we are performing a counter movement jump on a force plate, we are going to analyze several aspects. They're all derived from the force time curve, okay? So here, force plate can provide us the ground reaction force, acceleration, velocity, impulse, rate of force development, power, output, obviously not muscle power, is only power output, the displacement, and we can calculate the jump height. We can have several methods to calculate the jump height, working energy method, the impulse, and the flight time. We're basically using the impulse, one of the most reliable methods to calculate the jump height, okay? So here is one example of what we are going to observe when we are performing a counter movement jump on a force plate. The blue line is basically the vertical force, the ground reaction force. The red line or orange line over here, it represents the velocity. It's calculated from the force data, okay? So over here we have the one subject resting. We have the body weight, okay? Not body mass, we have body weight because we have here the vertical force. We have one unweighting phase where basically the individual is performing the counter movement jump performance, a braking phase, propulsive phase, and here's the flight phase. So over here in the flight phase, you can see that the data basically goes to zero because the subject is not anymore in the force plate. So over here, we are marking this phase to observe the jump height and observe this parameter, basically the flight time during the counter movement jump. So in over here we have the landing phase, where we have this little bit noise over here from the force data. Okay, so this is the basic illustration that we are going to observe in several articles that analyze the force time characteristics of the counter movement jump in the force plate. Okay, so we can have here 4 figures. We basically have the ground reaction force. This is a counter movement jump performed in the force plate. Everybody now is familiarized with the draw. We have the velocity in the red line. Here in the B, we have the ground reaction force and the rate of force development. We have the ground reaction force and the force impulse, ground reaction force, and power output. So basically 4 parameters that are analyzed from the force time curve of the counter movement jump performed on the force plates. Additionally to the force signal, we also can monitor the EMG from the muscles. So here is the raw EMG that we have analyzed in the lab. The muscle activation basically of the gastrocnemius during the jump. We can analyze the signal amplitude. We can analyze the signal moving RMS. Here is one example of the moving RMS of the EMG signals. We can analyze muscle activation, motor unit recruitment patterns. We can see lots of analysis. We can perform several analyses. They are basically synced with the force time curve obtained from the counter movement jump. Okay, so these parameters, they may be a little bit complicated. They require a little bit study. If anyone have some doubts about the data that I'm going to present, please feel free to send me some questions. I'll be available to answer all of them. Okay, so here we are going to present now this intervention, the fascia manipulation, and we are going to observe if this intervention may induce counter movement jump performance potentiation. So this is one question that we are trying to answer. Okay, I'm going to present some preliminary data. We have here a very simple experimental design. There is only one individual in this analysis. Okay, this is a young male, 107 kilograms, 1.9 meters of height. He's a highly trained individual. Okay, and basically the testing protocol, and it consists on performing 3 counter movement jumps without arm assistance at pre and post a fascia manipulation intervention. Okay, we also have a monitoring of surface EMG of basic lower limbs muscles. Okay, so just presenting a figure of this experimental design, we have here the counter movement jump at pre. We have all this analysis, the surface EMG of the lower limbs. Okay, here is the moving RMS of the surface EMG. Is basically a form to analyze the signal amplitude. Okay, and here the force time curve of the counter movement jump. We have here the fascia manipulation, and afterwards the fascia manipulation of the specific lower limbs muscles. We have the counter movement jump post. So this is the basic experiment designed to observe the phenomena of the post activation potentiation. We have only preliminary data because this is a very new research line, especially for me, to observe fascia manipulation. I'm learning a lot, studying the fascia articles. As I told you before, I'm just studying my research line also about strength and power. If basically heavy resistance exercise was performed here, we basically could observe the counter movement jump performance potentiation. Now we are asking if the fascia manipulation may induce the same phenomena. And we have here some very interesting results. Here we have the parameters obtained from the force plate, the peak vertical force, the rate of force developed, the impulse, power, and here we have jump height, and over here in the middle we have the signal EMG, surface EMG signal. So we have the max EMG RMS, the rate of EMG RMS rise in microvolts per second, and here we have the microvolts, the absolute values of the EMG RMS. Instead of looking the absolute values, I think it's a little bit easier to analyze the relative changes over here. So peak force has one increase of 11%, rate of force development 48% is a lot of increase in rate of force development following the fascia manipulation. Impulse has a little bit decrease, 12%, power increase 7%, EMG RMS increase 5%, the rate of EMG RMS rise decreased a little bit, 22%, and the jump height was a very slow increase over here, very small increase, 1%. But considering high performance athletes, this may be very significant increase. Okay, so this is only a preliminary result. We are starting to investigate fascia manipulation and this amazing phenomenon. Basically, for me, it is amazing. I consider, because I like this phenomenon. And this is our data. Thank you very much for your attention, and I hope to have helped you to learn a little bit about this phenomenon.
Yeah, thank you, Professor Bernardo. So I think that we have one question, and one is about the stiffness in the fascia. Just one thing that could be interesting to talk a little bit. And another one, it's about which points we choose, no, and what how we prepare the people to jump in and to analyze before and after intervention, no. So about this stiffness, what do you could bring some information about stiffness in the fascia, for your opinion?
Yeah, muscle stiffness is a very interesting phenomenon. Yeah, I'm really interested in studying how fascia may affect muscle stiffness. We are preparing future experiments. Basically, I want to finish these experiments and increase the number of participants. And afterwards, we really would like to study how fascia can affect the muscle stiffness. It's a very interesting phenomena. It has a lot of implications on muscle strain, power, and basically the post-activation potentiation. So it's a very interesting line of research.
Amazing. Another point is about how the points was choose. So I can explain this. It's okay.
Yes, okay.
Yeah, could be.
The fascia, as I told you, Johannes, fascia manipulation is not my expertise. I'm learning a lot. You, Angelica, and everybody at the lab. So the fascia manipulation is a very interesting line of research, but I'm not able to explain how was the manipulation, how long did you manipulate the fascia, if this manipulation, the volume, intensity, if this can increase or decrease muscle performance. So we have a fixed protocol that I'm going to ask you to explain a little much better than I'm going to explain, because I don't know the protocol. That's my question too.
Okay, I can do it. So, and one thing that's the fascia, it's tissue that connecting tissues and organs and many systems in the body, no? So today we have calling fascia like a fascia system. But we apply these points in the lower and the upper legs. And the points were analyzed, second ideas about the Stecco's manipulation. So we choose the point, the anterior and the posterior points, and then the upper legs, and near the quadriceps points, and the direction of the vastus lateralis points. And the opposite point is this agonist and antagonist. This is one thing. It's very, very important, this one, because if fascia connect everything, if you apply some points in tension, this point, this could reverberate the other side. So we apply these 2 points, so the force can transfer for one point of another one. So they connected each other. And the lower legs is the same near the gastrolateralis in direction of the gastromedialis, and the point near to the soleus point. So these 3 muscles are related to the jumping too, and in the front lower leg, more in the tibialis anteriors and the flexor longus hallux. So we apply for this in the vertical point with the neck of the hand, the fingers. So the vertical point is applied with a force like 2 or 3 kilograms. And we use 2 minutes and a half seconds for each point, just to use the same time. And we go until you feel the muscles and the tissue are less resilient to stretching. So we can find some tissue that can move, but still continue to create a resistance tension. So at this point we finish, and you can jump after this. And this is how we think about the agonist antagonist. So because still we have at this point a lot of spindles mechanoreceptors near these points too. We can stimulate them too. And another one is stiffness. So we intervene till in the stiffness of the tissue. So we can control a little bit the stiffness, mechanoreceptors inside, and the connection between the front part of the legs and the posterior part found the agonist-antagonist relationship. So they could coordinate better because we intervened at these points. So that we did in our previous research.
Thank you very much for the explanation, because this is one of my doubts. We basically performed the experiment together, but as I told you, I'm not a fascia expertise. I was just manipulating the jump high, manipulating the jump analysis of the individuals, which is very interesting to me. Thank you very much.
Yes, I think that as the researches are amazing, because they could help us to find new protocols for training or for intervention, just to become for the people, the sports for this way, to find new possibilities to become a little bit more stronger or a little bit more faster. So this could help then in their sports side and the sports training practicals, so they could help them to find new results. This is amazing.
Yeah. I'm very interested in these results because this presents a new possibility of warm-up for the athletes. If this was a good warm-up for strength and power events, maybe very useful, because we don't have energy expander, we do not have possible fatigue of the athletes, and we just have the performance enhancement. So I'm looking forward for the results.
Wonderful. So Professor Bernardo, thank you very much for the explanation, and I really appreciate your participation in our fashion movement and sports. And people, you still continued. In a short time, we have a practical class in a few minutes. So Bye-bye. Thank you, Professor Bernardo, again.
Thank you very much. It was a great honor. Thank you.
Thank you. Hi, I'm Wilke. Welcome to the Fashion and Movement in Sports. Jan Wilke is a professor and research in the Gurtner University, and in these last years he have been doing a lot of research in the fascia and which fascia are related in the force of transmission and with many other things in the health of people. And we appreciate you are here now with us, Jan, and what you are bring to us today.
Thank you, Johannes. Glad to be one part of this great online congress. Very happy to be able to contribute a little bit to this, and that we are able to do this despite the pandemic, which affects us all. So what I have brought is just a short presentation on foam rolling. Let me just share my screen, which you should now be able to see. So we chose the title Foam Rolling, Relevance in Sports and How It Can Be Used to Modify Force Transmission. And yeah, I just to describe a little bit my background. Besides being an academic researcher doing yeah, lots of stuff on the relevance of fascia from a mechanical point of view, I'm also working as a conditioning coach and as a consultant in the sports and fitness area. So that's my relation to the sports and exercise sector. So in football, in skiing, I've been consulting teams and associations on how to design exercise programs and how to involve fascia in their exercise programs. And I've also been working with elite athletes in football, for example, in a German elite football club. And I've been a conditioning coach, strength and conditioning coach of Angelique Kerber. He is a former Wimbledon champion. So that's just my background, and I want directly start with my presentation. So the first question is, what actually is foam rolling? I will always abbreviate the term with FR for foam rolling. And if you just have a look into the media or watch your favorite sport, you can see that there are many people using these foam rolls, and that's what foam rolling is about. So just take a roll, jump on it, and roll over the muscles and over all the soft tissue. And this kind of self-massage is what is called foam rolling, or also self-myofascial release. And there's a lot of stories out there and a lot of things people think foam rolling could do. So this is just a short list. So it can correct muscle imbalance, it can relax your muscles, improve joint range of motion. I don't want to go through all of this, but you can already see that there is lots of things people think foam rolling can do. And if you read all this, it's a little bit about like the holy grail, because if you read this, you think foam rolling can do anything. It can help you to be a better person, even, because it can kind of fix anything what's going wrong in your body. So that's what I found on the internet. So it's not a scientific description. It's just an overview which I found in the internet, what a person was saying. Look, that's what foam rolling can do. And what I want to show you actually is a more evidence-based presentation about what can foam rolling do and what is not possible. So what and how can you apply foam rolling in the sports and fitness sector with athletes? So just some general remarks. So if you do foam rolling, remember always that pressure is force per area. So if you see this will be painful because it's only one needle, which goes into a very, very small area. And here you have lots of needles or nails even, which are finely distributed through the whole body. So the force is distributed. So if you're using foam rolling and it's too painful, for example, if you're using a golf ball or a tennis ball or something very, very small, and you have too much pain, just use a second roller or use something else where you can distribute your forces and you will have less pain. So sometimes people say, I cannot apply foam rolling here or there because it's too painful, but that's not true. You just need to modify the conditions. Just use more rollers and distribute the forces so it will not be that painful. So you can use foam rolling in any region of the body, almost in any region. Then we have to look into how foam rolling may affect our tissues. So basically, from a mechanical point of view, we have two types of tissue deformation. The first is just a normal compression on the left side. You can see there is compression. The force is going up to down. So it's a downward force which compresses the tissue and moves it downwards. On the right side, you can see a different force application, which is shear strain. So you can see that the upper part of the tissue here is going into the direction where the hand is pushing. And you can see that the tissue down here, where shear stress stands, there the tissue stays more or less the same. So there is a shearing motion between the upper and the lower layers. And what do we do in foam rolling? I've recorded some small videos just to show you what happens. So this would be the first case. You can see here, this is just a normal compression. So if I'm just laying on the roller, there's compression of the tissue. What we very, very often do is this in the middle. That's what has not been shown over there. This is just simple rolling. So you can see I'm not compressing actively. I'm not losing and compressing. I'm rolling on the muscle. So it could be that I'm kind of pushing the fluids and what is inside here into different directions. And then we have a third possibility, which I very often use in athlete, but which is not that frequently known. And this is shearing. Also with a foam roller, you can create shear stress. So this is compression. This is only rolling. But you can also do shear stress and shear strain. So to achieve this, you need to use your hands and just don't move your body. And then you can move the roller. And what you can see here is that parts of the tissue are going in one direction while the other stays. So this may help to loosen restrictions in the tissue, for example. So there is different techniques and there is not one technique. You have to use the right technique for the right problem. So second question would be, what does foam rolling do? And I want to very briefly show you just some mechanisms which may explain the effects we see after foam rolling. So this study looked into the perfusion after foam rolling. So they did a very, very simple bout of foam rolling on the quadriceps muscles, and then they used ultrasonography with Doppler measurements. And what they found was that there is increased blood flow after foam rolling. So the first lesson we learned is foam rolling can increase blood flow. So if you want to have more blood flow, that can be important for pre-game warm-up, for example, but also for recovery. You can do foam rolling and you will achieve an increase in blood flow, the same as after normal massage. The technique for this probably will be rolling, of course. A second mechanism of foam rolling is that it can modify gliding, and we have studied this in one of our studies. So we did foam rolling, and as you know, the fascia is composed of several layers. So we have the adipose tissue under the skin, and then we have the superficial fascia, and then there is the fascia itself, the muscle fascia or the deep fascia. And the deep fascia, and you can see it in the ultrasound image, which is shown in the middle, has different layers. And what we found is if you do foam rolling, you can increase the sliding of the layers. So for this, you can use both the rolling technique, because that is what we use, and probably, we did not test this so far, but probably I would expect that shearing would be very, very effective to achieve this better gliding of the fascia. So if you want better gliding, do rolling or do shearing, the shearing technique I just showed you. And then there is another functional change that we can observe. We did another study where we did foam rolling with different speeds. So we did fast foam rolling, very fastly going over the muscle, and we did very, very slow, gentle foam rolling. And what we found is the speed does not matter. So you can do it fast, you can do it slow. It doesn't really matter. The effects are more or less the same. You will increase range of motion. But what changed was that we could decrease the stiffness. So it's less hard. So this may be important if you experience some sore muscles. If the muscles are very, very stiff, you may be able to decrease the stiffness with foam rolling. And the technique, of course, is foam rolling, which we use, but I think it could also work with compression techniques. And I added a slide with a but, because I showed you lots of adaptations in the tissue. So the tissue is less stiff, there is increased blood flow in the tissue, and you have a better gliding. But the effects of foam rolling are not only morphological, related to structure, related to the tissue, they are also related to the nervous system. And this is very important to consider, and you can see it here. This is the change in range of motion after foam rolling, and the lines show the control group, and this line at the bottom here, this is the massage group. So here was foam rolling performed, and you can see an increase in range of motion. But the line in the middle, this is the control leg, which has not been rolled, and still we see an increase in range of motion. So this means if you do foam rolling, you will increase range of motion in the treated leg, but you also have effects in the other leg, which means that our nervous system seems to release the tension generally. So all the effects we see are both structural and neural. So how can foam rolling help athletes? After now we know what foam rolling is and what it does, let's see what we can do. And the first issue would be range of motion. So how can we increase range of motion? And you can see with this guy, range of motion is kind of important. So what we did was a systematic review with meta-analysis, and this is a very, very recent paper we published just 1 year ago. And I don't want to bore you with too much science, but I still think for practitioners it's very important to understand these graphics. So this is a very, very short walkthrough. A meta-analysis does nothing else than just combining all the studies, all the individual studies that are out there, and calculating the effect over all these studies. And that is way more reliable and way better to interpret than one single study, because another study could find something completely different. And to understand this, it's very easy actually. So what we see here is just a list of all the publications, all the articles we included. What you can see here is the effect of any of these studies. And the only thing that is important for us is the one down here, the small one. You can see the very, very small diamond over here. This is the combined effect of all. And if it does not cross the midline, there is an effect. And to help you with interpretation, I put these photos so you can see this is the in favor of foam rolling, and this is the couch potato. So this is doing nothing. So if you compare over all studies foam rolling against doing nothing, you can see a clear effect. Yes, foam rolling helps, and it can increase range of motion. So the second question we had, because it's very important, how does this relate to stretching, for example? Because people might ask, should I do stretching or should I do foam rolling? So the answer is, You can do both, because you can see here the combined diamond, combining all the study, is on the midline, which means he cannot decide for one direction. He says, okay, it's kind of the same. It's directly in the middle. So both stretching and foam rolling are as effective, equally effective. So you can do both. Maybe even combining them, do first foam rolling and then stretching, or the other way around. So that's range of motion. So let's talk about recovery. Recovery is very important for many athletes. You know, if you have huge training loads, you need to think about how you can help your athletes to recover faster and to perform better on the next instance. So this is one study. There are many out there, but this is just one example showing you what foam rolling can do regarding recovery. And what is shown here is the fatigue as rated by the participants. So the participants were asked to after doing exercise, they were asked to rate how exhausted they are after the exercise. And there were two conditions. The first was foam rolling, and the other one was a control condition, planking, because it's a very similar movement. If you roll the quadriceps, you're doing it in a planking position, and they did planking without the foam roller. And what you can see is there is an effect of foam rolling. It can increase or decrease the amount of fatigue, and that's the central message. So if you do foam rolling, you can reduce muscle soreness and you reduce fatigue. And this is a similar study which did a similar thing. Depicted here on the left is a rating of muscle soreness. So they were just asked to rate muscle soreness from 1, no or very, very small muscle soreness, to 10, maximum muscle soreness. And they even had a look on the following days. In the graph, you can see post 24, post 48, and post 72. So after 1, 2, and 3 days. And you can see this is the line down here. This is the foam rolling treatment. You can see if you do rolling, muscle soreness will not be as strong as if you do no foam rolling. So it seems to help in this direction. And they also had a look on some functional parameters, because you may want to know how this affects strength and jump height and all those things, rate of force development, which is RFD. And interestingly, there was no major effect on motor outcomes. So there was a small improvement in jump height, but basically there is no large effect on performance, which is okay, because we can decrease muscle soreness, but we cannot affect muscle function so much. So if you say, okay, we can improve recovery, we may ask, what about timing? So when should I do the foam rolling? Should I do it before or afterwards? So in short, timing matters, and you can see here, timing is very, very important. So if you're running this parkour, you want to get to the finish line. And if your dog stops right now, this makes you very, very angry. So timing is important, and that's what we wanted to know in our study here. So we did a fatigue protocol. Our participants were fatigued with exercise, and we had 3 conditions: a control conditions where they just had the fatigue protocol, a second condition where we did preventive foam rolling. So they did the foam rolling before being exhausted with exercise. And then we had a third condition where people did the exhaustive exercise and then they did foam rolling afterwards. So we wanted to know, can you do preventive foam rolling, rehabilitative foam rolling, when it is best? What is the best timing for foam rolling for recovery? And what you can see here in the image on the right, the white circles, these are the control conditions. And what we see here is the loss in force. So you do the exercise and of course you will lose force if you're working out hard. And you can see each circle here is one participant. So you can see most participants had a loss in force because the line would be no loss. It's just 0. And you can see it here. So there is a loss in force. And the other 2 conditions, you can see that there are many participants which are around the dotted dashed line over here. So many participants who did not use a lot of force or even gained some force despite the fatigue protocol, and only very few down here which had large force losses. So there is no big difference if you do it before or afterwards, but you can reduce the force loss. That's the finding of our study. So slightly contrary to the studies I showed before. But the important message is it does not matter if you do the foam rolling before or after your exercise or after your sports to help recovery in athletes. So the last area here would be pain. Let's talk about pain and how foam rolling can affect pain. So there is some studies showing that if you have tender or painful spots in your muscles, which you roll, then you can measure pain. And this is just the pre and post test over here. Pre-test is down here, and the post-test after rolling is the upper line. And you can see there is an increase in the pressure pain threshold, and an increase in pressure pain threshold, which is the point where you experience pain if you press on the muscle. This goes up, which is good in this case. So the later you feel the pain, the less sensitive you are. So there is less pain if you do foam rolling. That's the short message of this. And this makes it very interesting for myofascial trigger points, because many athletes do have myofascial trigger points. Myofascial trigger points are knots in our muscles. You can see it here, which are painful. So you can palpate this. If you touch your muscles and just search, then you will find some very, very painful spots. And these may be myofascial trigger points. And they're very, very simple criteria to identify them. And I want to show them to you because it's important, an important thing to work with in your athletes. So the first, as I said, is a palpable knot in a taut band. So there is a very, very taut band. You find a knot, and it is painful if you compress it, if you touch it. Then you have referred pain. So if you touch this point, the pain will radiate to other regions. For example, it could go down your leg if you're pressing in the hip. And you have pain recognition. So if you have an athlete with Achilles tendinopathy and you press on the calf muscle on a trigger point, he may say, yeah, now my Achilles tendon hurts, although you're pressing here. And you may see a local twitch response and a jump sign, which are both things you see. For example, the jump sign is if I press here on my neck, you can see it in the video. I may move my head very, very quickly, and I can't prevent it. So if you do it once, the person or the athlete may just have been surprised. But if you repeat it and he does constantly the same thing, that's a jump sign, and it's a sign for a myofascial trigger point. And besides these active trigger points, which we do have in pathologies, an active myofascial trigger point is always related to pathology. But also in healthy participants, which do not have a pathology, we can find latent trigger points. And these are important to treat for you, because the latent trigger point causes some problems. For example, and I want to show you this, the latent trigger point causes a higher risk for cramps. Very often in sports, we see people cramping who cannot continue with sports and exercise. For example, in football or soccer. You also see faster muscle fatigue. People have to athletes have to be exchanged after 70 and not after 90 minutes in football, because they're exhausted. And they can move to an active trigger point, then causing a pathology. So we need to treat the latent trigger points. We have the same criteria, I listed them here again, to identify latent trigger points. The only thing we don't have is a pain recognition, of course, because there is no pathology, there is no pain to recognize. Okay, so in active trigger points, you have all the criteria, you recognize your pain because it's related to your pathology. In latent trigger points, you have the same criteria, but you don't have a specific pain area you want to talk about. So there is no pain recognition, but basically it's the same. So we wanted to know in the study, is it possible to treat these myofascial trigger points? And what we do was comparing 3 conditions. So we identified latent trigger points in healthy participants. Just remember, in healthy participants, we do also have the latent trigger points, which may be a risk for active trigger points, which may cause fatigue, and which may reduce force production in the muscle. So it's good to treat them continuously. And it's an argument to use foam rolling, even if you have no problems with your daily routines with athletes. So there's 3 conditions we tested. The first is just a simple compression. I showed you the videos before, just compressing the trigger point. The second was rolling over the trigger point, because we wanted to know, is there a change if I do rolling? And the second was a placebo treatment. We used an ultrasound and a laser needle device which emits laser, and we kept it making noise and all this stuff and crazy lights, but the laser was switched off. So there was no laser, but the participants thought, okay, there is a laser treatment which will help my muscles relax. And what we found was there was only one treatment that changed the pain from the latent trigger point, and that was the static treatment. So as we expected, there is no significant change in the placebo treatment, and there is also no change, even less, you can see it here, with the dynamic rolling. So we need to say, if you want to treat pain and trigger points, don't roll. It's not effective. It will not work. You need to compress. What you can do is compressing. You can see it here. This one, compressing, works with trigger points. So the technique is compression. So, and now let's get to the last part of the talk. How can we use foam rolling to modify force transmission? Of course, you can use foam rolling for many applications, as I showed, just to treat pain. But one of my fields of research is myofascial force transmission. So we decided to relate this to each other to make a connection between foam rolling and force transmission. And just to give you a brief introduction of what force transmission is. Force transmission is the application of a local force. This guy is a very strong man, obviously, and he is pulling on the rope, and he's trying to move this train, and he can move this train maybe if he's strong enough because he has this rope. So the rope transmits the force he is applying to another object, and that's what we have in the body as well. We have two muscles. The two muscles need to be connected by something, by a tissue. And if one muscle exerts force, it will maybe move the other one or mechanically affect the other one. And we often talk about this in the concepts of myofascial chains. You know, there are concepts which suggest that the muscles are not separate, but they are connected to each other. So these concepts suggest, and we have tested them in our works and shown that some of them are really well. So there are connections, so the muscles do not stop. For example, over here, so the calf muscles do not stop at the knee joint. The muscle stops itself, of course, but the fascia surrounding the calf muscle goes directly into the fascia of the lower posterior thigh muscle, and there is a connection. And the same is true for the lumbar spine, so there is a connection to the erector spinae muscle as well. So there is apparently a connection. And we did a very, very interesting experiment lately, just 1 or 2 years ago, where we had a look into this direction I just told you about. And the calf muscle does not only have a connection up here to the posterior thigh muscles, but also, of course, with the Achilles tendon to the foot. And we focused on this region, and what we did was a simple experiment. We had a dynamometer, which you may know from rehabilitation clinics. Some fitness centers do also have these machines, which can apply a passive force over here. So if you lay here, you can attach the foot to the machine over here and apply a motion, which will, in our case, do a dorsal extension. So the foot is going into this direction, as you can see, with the arrow over here. So there will be a stretch of the gastrocnemius muscle. So the gastrocnemius will be stretched. And we wanted to know, if we stretch here and there is a connection over here, like the guy pulling the train, can this line of pull affect the posterior thigh? So can we see anything here? If so, we should be able to see movement of the tissue over here. So it should move into the direction of the machine. It should move to the right. And we used ultrasound, high resolution ultrasound, to study this during this experiment, during this motion. And what you can see here in the right picture, in the video I'm going to show soon, you can see the muscle, of course, and you can see the fascia, which is the white lines. Yeah, it's the deep fascia here, the second white line, and the superficial fascia over here. And I will just show you the video, what happens during the motion of the foot. So the foot is moved, and what you can see in the video is that there is a movement of the tissue. Yeah, you can see it's not a lot, but you can see the tissue moves into the left direction. Don't be surprised, the video is just the other way around. So the movement goes into the direction of the foot. So it's just for illustration over here. But you can see it, I will repeat, just focus on the whitish parts of the image. You can see that they are moving into the direction. And after stopping now, they are going back into the other direction. So you can clearly see motion. You can clearly see how this black part has moved. So this is one of the first proofs we have in vivo and in vivo conditions for myofascial force transmission in myofascial chains. So this was a very important work for us. So how can we use it in our athletes? So there is myofascial force transmission in human bodies, and how can we use it in athletes? And I brought you two examples because I think these may be some you could see in your athletes. Very often it's runners and football players who have pain at the plantar side of the foot, plantar fasciitis, or fasciosis, even called, because there is not always inflammation in the tissue, is a condition that affects the part between the plantar side of the foot and the heel. And people have problems when running. People have problems when engaging in football or soccer. And what we saw when we searched the literature is that there is problems in the hamstrings in these people. So the people who have plantar fasciitis or fasciosis, they very often have a higher stiffness of the calf and even of the posterior thigh muscles. So it could be that the higher stiffness somehow transfers down to the plantar fascia and to the Achilles tendon, transferring the force, and over time, not during one acute situation, but over time, over weeks to months, causes this problem. So it may be effective to treat only this region locally with shockwave treatments, with stretching of the plantar fascia. You can do all this. You can do foam rolling of the plantar aponeurosis, but you could also try to add foam rolling or stretching of the hamstrings or the calf muscles to relieve this. And the second and last example I want to show you is also something from football. Very often football players experience problems in the adductor muscles or in the abdominal muscles, you know, because you can see it in the picture nicely. If you're shooting, you need core stabilization. So this could also be an example for any sport, because in many sports you need core stabilization and you need leg activity. I think Johannes was a great karate fighter, and he knows about this. So if you want to strongly move your foot, you need stabilization in your core. So, and if both work together, they develop a lot of force. And we know from one of the myofascial lines, there is a diagonal line on the front side of the body, which goes from the shoulder of the right side, for example, here, from the pectoral muscles over directly into the rectus abdominis muscle, so in our straight abdominal muscle here, and from there is a connection to the adductor muscles. So there is a connection between the adductor muscles and the rectus abdominis muscle. So it's not surprising that there may be a problem, because those muscles pull on the symphysis a very, very small area. The insertion is very, very small. And very often when I worked with football players, they came and they had problems with their adductors. And then we fixed the problem and it was okay. They got back to activity, and then they came back and said, okay, now I have abdominal strain. And I was very surprised, because I said, okay, that's another problem. Okay, let's see. But no, to me, it's not surprising, because both muscles are connected by means of the connective tissue. And if you do therapy on the adductors for the adductor strain and you strengthen it, you will create a new disbalance, and you may have problems in the abdominal muscles. So if you work on these problems, always to work on the abdominals and the adductor muscles. Do not do therapy locally. And these two examples should show that you could work on both. Do foam rolling of the adductor muscles, but do core stabilization exercises as well. So combine your therapeutic approaches. And just to show you one last treatment you can use if you do foam rolling, a very popular treatment is just doing a self-massage of the foot, for example. So if you have the problem with the plantar fasciitis in your runners or your football athletes or whatever sports they are coming from, and they have the fasciitis, you can train them and let them do the self-myofascial release exercises. And in one study we did this treatment exactly, and then we did a sit and reach measurement, which measures the stiffness of the hamstring muscles. And we found if you do this, you will increase range of motion and extensibility of the hamstring muscles. So there is a possibility to treat non-local and have effects in other body regions. So if you have these problems, do use techniques such as foam rolling to get this solved. So I want to summarize my talk with a few key points which might help you to get the scope and to recover and keep in mind what I was saying. So foam rolling generally increases range of motion, and it is as effective as stretching. So you can use both foam rolling and stretching to increase flexibility. There is no major change in motor performance. This can be good and bad as well. Of course, you could say there is no change. That's sad. I would like to have an increase in force. But you could also say it's good that there is no change, because, for example, if you do static stretching, you will have a decrease in explosive force capacity. So never do static stretching before sprinting, before explosive sports, because it will make you slower and less powerful. You have two possibilities. You can do dynamic stretching, which is fine because it does not decrease explosive force capacities, or you can do foam rolling because it also has no effect on power capacities, explosive force. So depends on the angle of consideration if it's a good or bad thing. And then foam rolling improves recovery from a functional point of view. If you would examine some markers or chemical agents, I think there are no effects. So I think it's more a sensory effect, but you can improve recovery, and especially muscle soreness that can be reduced with foam rolling. And it does not matter if you do it before or after sports. You can do both. The effects of foam rolling are related both to the tissue and to the central nervous system, as I showed you with the one slide, examining the effects of those. And then we have different techniques. Remember, we have compression, we have rolling, and we have shear strain, and you can apply all these three techniques depending on what you want to achieve in your clients. And foam rolling, of course, it can be applied based on myofascial chains. Just have a look, how is the course of these myofascial chains and how can you apply it? And maybe this will help you in your clients. So that's all for now, and hope you enjoyed the talk.
Thank you very much, Jan. And I have some questions.
Sure.
Which one is simple? What is the difference between shear and strain?
Yeah, it's actually not a simple question. It's a difficult one, but I will try to explain. So, if you have actually shear is also strain because it's a type of strain. So you can compare elongation and shear stress, for example. So if you have shear motion, you will move two parts of a tissue, two bodies against each other. So what you create is shear forces. If you do elongation, which is what we do during during stretching, you will pull two things apart. So you elongate the tissue. And this is important to imagine because we have so many things we can do with our clients and our athletes. So we can do a stretch and elongation. This is stretching. We can do compression. This is foam rolling. We can do shear strain, which will be moving the things. It's like I take one part while the other does not move. I move it into different directions. That's shear strain. And I can do rolling, which is pushing the fluids in different directions. So there are many possibilities, and yeah, it's good to use all of them.
You're wonderful. And could you stop the chair?
Sure.
Just and Just one question that we received here is about the perfusion. What about the foam roller could improve more diffusion of the nutrients? Yes, about the perfusion in the blood and the veins.
Yeah, that's a very, very important point. As I showed, foam rolling increases perfusion, and this is very helpful for us from different points of view. So the first is if you do exercise, you accumulate a lot of agents. You have lactate, for example, and of course, if you recover, you want to get those lactate away. You have inflammatory agents. You want to get the inflammatory agents away. So it can help you, and I think that's one thing about the recovery thing. Why foam rolling helps? It can help you to more quickly restore the normal situation, and I'm not sure if it can distribute nutrients very, very quickly because they're not only in the blood, but it's certainly a very interesting idea that if we increase circulation and if we increase perfusion, then this helps us just to kind of help pushing metabolism and to increase metabolism in the area where we are working.
Amazing. And then the last one, what do you think about the people older could be used the foam roller for, because you start to speak something like this, for because we are talking about the sports guys, but for the aging people.
Yeah, I mean, there are older guys which do sports too. So
it's
not about sports and young persons; it's about all of us. So and thank you very much for asking this question, because there is also some things we need to consider for safety, for example. So I was only showing effects, and there is big discussions also going on is it safe to do foam rolling? So many people ask. Can it be a problem? Can I hurt? And I see many people doing foam rolling, applying foam rolling without worrying about what they're doing. So we need to remember that foam rolling is a very, very strong technique acting heavily on the tissue. So we really need to be careful when applying this. So we need to know, is this person healthy? Are there any diseases affecting circulation? So as soon as there are any diseases which arteriosclerosis, for example, anything that severely modifies perfusion and the whole circulatory system, we should be very, very careful, or even not apply foam rolling. The second is do not roll over bones. The third is be careful not to compress any nerves. So if you have strange tingling feelings or something, or strangely radiating pain, be careful, talk to an expert. And regarding the older people, I think it's a good thing for older people, because during aging we get less flexible, we have less range of motion, we lose motor capacity, and of course you need to keep working out to do strength training and normal sports to maintain function, but foam rolling can definitely help you to maintain mobility and flexibility, because we know from our studies that the fascial system changes during aging, and that there is less elastic fascia, that fascia becomes stiffer, and as I showed, we can modify stiffness. So foam rolling may be helpful to change these elastic properties. But again, we need don't leave the old people alone. I think that's very important always. From a general point of view, we should not leave old people alone, but also to during sports, monitor what they are doing, because particularly in those people, if the tissue is not that resilient and not that flexible, they can hurt themselves more quickly than younger people. So the older the client or the athlete gets, the more closely he or she needs to be monitored and participated by or accompanied by the therapist or the trainer.
Okay, Jan, thank you very much. And hi people, we will still continue. And thank you for you are with us in the fashion movement and sports. And thank you again Jan Wilke, and bye-bye. I see you soon.
Bye-bye.
Bye.
Thank you very much, Johannes.
So now it's a pleasure to introduce Johannes Freiberg from São Paulo do Brazil. Johannes is a professional in sports science, he's a rolfer, a manual therapist, master fascial fitness trainer, and is part of the team of a fascial plastination project. And he's also a Pan-American and world karate champion, so he has a huge experience in movement and the knowledge about the fascial system. So how are you, Johannes? Fine?
Fine, I'm fine. Thank you, Anne, for introducing me for all people. And I'm a pleasure is here to stay with all of you in this nice project. This is Fascia Movement and Sports. And thank you for stay with you here now.
We are cooperating in organizing this.
Yeah, we are in a group now. This is a large group since Brazil, Fascia Robert Schleip's group, and FISICAMENTE FORMAZIONE. And so this is a cute group now.
So what are you going to teach today?
So we understand that the people in the world are becoming more elderly and for the future, and that they are becoming maybe in 2050 we will have 2 billion elderly people in the world. So now we are trying to understand how the process of aging is coming for us, and I will prepare for the stretching for health elderly. So this is my focus.
So do we need something, special tools or everything else?
No. This is only a small chair inside you, and you can work in the floor if you have a mat for your comfort, and you use sometimes a wall. So you need a wall, a mat if you would like, and a small chair for working a little bit.
So ready in 2 minutes.
Okay, see you soon.
Bye.
Bye.
Hi, welcome to the fashion movement sport, and we are talking about stretching. Now in the online, it is a new way that we are using this platform to teaching you. So the fascia is extremely related of the aging, and have many things that are related of aging. So what do you know? That if you do something, activity physical, and the fascia could be reorganized itself during the movement. So today, the olders are people that have been used a lot, the stretching and more power training to improve their muscles activity. So in different ways, we have different kinds of exercises. So the fascia are two related of different kind of exercises. But today, we are more in direction of the stretching to improve the odors, to become more refresh the tissues and then reorganize the tissue continuity. So the stretching, it's a way that we haven't been thinking that could be nice to understand how we become older along the time with well health, okay? So now we are going in this way. So prepare yourself. So we are starting just to balance, and the body is a dynamic process that we have been thinking how fascia could be related in this dynamic movement during the exercise, of course, during the day. So the fascia is as a dynamic system that we have been know more and more. And this three-dimensional organization of the fascia systems is related so give us the impression that we need to move in different ways. So beginning to start and move, but no, it is not only the anatomy, but how this anatomy are organized inside the body. So we have bodies, legs, arms, trunk, and so this one. So keep balancing your body in each way. Just breathing. So relate the balance between legs and arms in opposite position. And now in diagonal movement. So fascia is different layers in different dynamic positions. So we can see different ways. Because not only muscles, but because the fascia are organized in tri-dimensional, and we have a different kinds of movement related of these balances. So a little bit more improved balance. And situation lateral, and medial movement. So we can bring the tissue for the tension on more inner and outside. Inner and outside. Then we begin to balance this front and back. Just push your arms to back and front. So feel this balance, how we can organize our body during movement. So the movement are two related with the gravity, and the gravity is related with the fascia too. So we can balance and still a little bit more dynamic. Follow me, inspire, expire, relate, rolling yourself and stretch. Rolling, and now more back and up. Stretch the arms and balance back. Stay a little minute, open your chest, then open back, close, open these arms, look out, and then boom. Then we relate. So spine, in spine, wow, 1, 2, 1, 2, 1, and now one more time, 1, 2, go up, stretch, yes. Now, so since the beginning, fascia is related to connecting all the things. So think the first molecules, then new cells. So the complex systems go in direction to create a complex movement in the spatial. So go out, so open your hands, open and close the hands, there's torsion. Bring the movement, so in, out, open the hands, so working your fascia palmaris, go up, then close. Rotate your arms and up, 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 outside, go in. Then balance you. 2, 3, 4, 4. Yes, okay. Now go in direction of diagonals. 1, 2, 3. So prepare the fascia is like to prepare yourself to start to begin already to move when you need. No, so diagonal it is a kind of direction of your body. So the balances create a more dynamic opportunity, the organization of how you need to go. So 1, 2, 3, 4, 3, 4. In the continuous balance, now for one leg and another one. So each, 2, 3, 4. Okay. Now continue to work in the arms. Now more retinaculars. So the retinaculars is like proprioceptive systems. Then we need to work every time. So bring the hands in direction to touch. So touch, firm your arms. Then go. Stretch, stretch, and come back. Push, push. Then go. Go. Come back. Again. Open, open, open. Include the neck. Include the throat. Include the chest. And close. Open back. Open front. One more time. Yes. Now the opposite. 1, 2. Now sustain your hands here. Then open, open, go, 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 up, 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 and the last one, up, up, go, yes, up, yes, then rotating, up, go, this movement inside, outside, in, go, the once, go, yes. Now we are going to begin to start to working more push press, okay? So we need to use the, a little rebound now. So we go 1, so 2. So the fascia is very, very important to organize and to help the system to not to use too much energy, but use more balance that could be help to in endurance. You have more and more movements for more long time. This is like a kangaroo. So we need to do this 1. Yes. Now put your arms more isometric movement now. So just start not to use too much rigid movement, but stay here. Then start to elongation your gastrocnemius and the soleus. So go with elbows. Stay a little moment. 1, 2, 3, 4, 5, and come back. Now go up with the calcaneus, then flex. Then now we are going to work a little bit more soleus and organize more soleus in this movement. So just stretch soleus, then more gastrocnemius now. So sustain your legs, more straight legs, then going like this small movement like you are jumping. Now we are completely jumping, no? So first of all, it's like kangaroo, then flex, then calcaneo, whoop, then jump. 1, 2, 3, jump. So solio, then gastro. Hey, you, those, 3, 4, and now a little jumps, going, yes. Now we start now to walking, doing a gait. So first of all, we are prepare yourself, put the calcaneus in one direction, in another direction, then doing a little bouncing, just beginning to stretch the back side, go in this direction, more inner, try to elongation more the outside, then the other side more outside, you are feeling with the outside of the legs. Then change the calcaneus, one direction, and ischium in the opposite. So stretching like pushing the floor, then more inner, so inner, then the outside. So move in this short balance. Wow. Then put the fingers close to the wall, then up your calcaneus, then flex the knee and this balance first. Then use your calcaneus to move you for front. 1, go, 1, then your legs inner, then the outside, change the position of your front feet, then come back, change, up, knee, and now this is the front leg, then use your calcaneus to balance you. Then turn out the front feet, then in, then move your calcaneus too. Wow. Down we are starting to walk. Okay, first of all, hands, feet, stabilize your front. Then you bring your knee and start on. Go, and balance like a big movement to walk. So 1, 2, 3, 4, 1, 2, push, bring, 1, 2, in front is more front than back. Yeah, now just rotate and begin to start to work your iliotibialis, and now the other side, front, back. Maintain your hands on the floor, create more tension inside the body. This is a close. 1, 2, 3, front. 1, 2, 3, being 1, 2, 3, 1, 2, 3, being 1, 2, 3, front. Calcaneus. Stretch. More isometric and eccentric movement. And the last one, 1, 2, 3, out, in, use more trato iliotibialis. Come, in, go, adduction, adduction. One more time, abdux, abduce, yes. So now we are doing the pendulum. So prepare yourself, stabilize one leg, the other could be balanced, then just balance. 1, 2, 3, just move your pelvis, then at the end, a little flex. 1, 2, it does a micro mini balances. 1, a small stretching. So the other side, 1, like a kick. At the end of movement, you bring a little bit more tensioning, then create a mini bounce at the end of movement. Wow. Then we start in a new movement. Take your chair. So, look, now you are rolling, working a little bit more spine. So, put your hands on the knees and start bringing the chest inside, expiring, inspiring, expiring, inspiring, inspiring, expiring. A little bit more, go and come back, doing movement in, out. Use your rectus abdominis or pectoris. Go. In, inspiring, open, 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 expiring. In, out. Inspiring, expiring. So, just a little balance. Lateral line. Yes, lateral side. Then hands 1, 2, inspire, open the ribs, then open the ribs. And this hand, put on the legs, create a little tension here, and organize, contract this side, open this side, inspire it. One more time. Yes, the other side. Put your hands here. 1, 2, open ribs. 3, go. Look. 6, 7, yes. Now we are using the chair to organize. Now we are beginning to work a little bit more in the pelvis, doing this movement in the balancing one side to the other. So open your legs, 2 sides of your shoulders, and we are doing this movement. Just cross the tension from one leg to the another. 1, 2, 3. Use the feet to push you from one side to the other. It's like skiing. This movement, 1, 2, and 3, and 4. Now flex and use the balance between side by side. 1, 2, 3, 4, 5, 6. Out of chair. 1, 2, 3. At the end, the balancing. 1, pump, thumb. The arms one direction and the legs the another direction. 1 and 2. Now cross. 1, 2, 3. Go to the other side. 1, 2, 3. So 1, 2, 3. Calcaneus at the leg, the back leg. So the other side, 1,
2, 3, one more time. 1, 2, 3, the last one. 1, 2, 3. So now in squat position, put the hands on, flex the 2 legs, and go on front and back. Just to push your pelvis in one direction, in your arms and trunk in another direction. So create a 2-directional movement. So create a little bit space here, a little bit more. Now stretch just one leg. Just one leg, and push the arms, and balance 1, 2, 3, 4, 5. The other side, it's the same way, 2 flex, extend the side, open the arms, balance 1, 2, 3, 4. Use your belly muscles to help you to move. Not just the shoulder, but these muscles. Pump, he come back. Then he's stretching. Go in front, inspire just to relax. Come back and flex. Just one more time. And come back. So put outside the chair. Then we work a little bit more agora, and now fascia thoracolumbaris. Okay, so rolling. A little bit you could flex a little bit your knees. Put the chest, so bring over the pelvis over the pelvis, and the pelvis over the legs. Stay there and a little bit bouncing, like you would like to take off something on the floor and create this balance. Then more on the left side, use this movement to pick up something on the floor. Yeah, come. Yes, now fit outside, do it same. Just a small balances, like shoulders go and come back. Now fit inside, same. Go, take something off the floor. Yes, change your position. Yes. Now, straight back until 45 degrees, then come back. 4 or 5 degrees, start to use a little bit more your gluteus and your ischiotibialis and or your extensoris spinae. Balance. Yeah. Balance. Use a little bit more this movement to stand up. Then arms front. Stay in position of the squat. Then up. So okay. So now go to this diagonal and the opposite diagonal up. So go in direction, rotation, the legs, then up. Go rotation, legs, and up. The movement is like, at the end, this is a little bit torsion. That is like you would like to throw something. Then you catch and bring. So rotate, do this movement now. 1, 2, 3, then 4. In 1, 2, 3, and 4. One more time. 1, 2, 3. Go. So the other side. In 1, 2, 3, up. And 1, so torsion, 1, 2, 3, go. And 1, 2,
3, go, and the last one. So working this diagonal up and below. So the last one, we are going to the floor, doing some rolling. We start to work in more deep tissues for abdomens with legs and arms. Put yourself in the position of the starfish. Then go with the right side to the upper, contract in diagonal. Then go the arms over. Then balance these legs and stretch like appendiculation. So you need to find some more space between hips and the ribs. So working a little bit more here in the quadratus lumborum. Try to find more the raphe between transversus abdominis, back and front muscles. Then these legs go front, close here, but open the chest and balance in different directions and open. Stretch in your more the pectoralis and the rectus abdominis as well as serratus. Then change again and balance legs here working. Gluteus minimus, tractus iliotibialis, a little bit more your gluteus, but also canthus dorsalis in direction of quadratus lumborum. Then this is the last one. Balance your arms and maintain the obliques in direction, opposite direction of your arms. So contract in this side, but opposite side open. Then, wonderful. So the last one, so come on. So it's the same. The legs stretch, arms straightening. So a little bit balance. Started to work in the quadratus lumborum, go in direction of the raphe. Then you would like to organize more space between ribs and here, the hips. Then go the legs front, close in front of you. Use the muscles, abdominal muscles. Then you start to balance the arms a little bit up of the floor, like 30 degrees, and maintain the pectoris active, not relax the pectoris, or the opposite. Start to use the pectoris a lot with the rectus abdominis. Then change, balance the legs, no? Then create direction for the opposite side, this contralateral position. It's like walking, no, it's just like we did this in the wall, but that's the end of movement. Then again, it's a gate, close, force here, and adductors, and open the chest. So here, close in front, open back, upside. So in contralateral, one side close, and the other side open. This. Then we are finishing, close, push legs in front of you, just to sit and put yourself in position for the quadrupeds. So movement bring for us a different way. We can use this for find new movements to create with your arm imagination, no? So, like spine is elephant walking. Just to do this, flex one side and the others. So the one part of to create different kinds of movements, it's expression of your body. Not just movement, but trying the ways that we can find new possibilities. So front and back, lateral inside, diagonals up and down. So the creativity means possibility. So the possibility comes with the fascia training because we can find new ways.
So, thank you very much for all. That's me with Pelé. Pelé this year are doing 8 years. So they are aging well. As well, I would like to myself. And then it is me. So in my long time, I have been practicing karate since I was younger, still today. And of course, most part of my knowledge comes with the knowing that the movement is very, very important for all of us. Thank you very much. And I see you in the next time. Thank you.
So I'm very pleased to have you, Sebastian Bohm, to be lecturing now. You will be replacing Professor Adamantios Arampatzis, who had to cancel due to a very short-term travel obligation. But we are very happy to have you because his talk was supposed to cover mostly the research that you had been spearheading with his research, focusing on muscle-tendon interaction. I think you are a postdoc at his department of Training and Movement Science at the University in Berlin. And you are the leader of the working group that focuses on tendon-muscle interactions. So I'm very happy to have you present the latest findings about this presentation.
Yeah, thanks, Robert, for the nice introduction. And of course, thanks the organizers for putting up this beautiful event. Okay. Okay, so first of all, again, thanks to the organizers to invite us to contribute here, and my talk in the next minutes will focus about the functional importance of tendons and then how they can be trained in order to improve performance and health. Tendons link the muscle to the bone, thus transmitting the forces generated by the muscle to the skeleton in order to produce movement. Tendons are very stiff due to the high amount of collagen type 1, yet they feature a certain compliance that allows the tendons to elongate upon loading. This relationship can be illustrated in the typical force elongation relationship with increasing elongation at higher applied forces. The slope in the linear region of this relationship is a so-called stiffness, a measure of the resistance of the tendon against load. That means the higher the slope, the higher the force needed for a given elongation, the higher stiffness. Because of this dependency of muscle strength and tendon elongation, muscle and tendon should be recognized as an interacting functional unit, so to call the muscle tendon unit. Within this functional unit, the tendon features important functions. As mentioned already, it's not only the transmission of force generated by the muscle to the skeleton. Furthermore, it's the elasticity of tendons that enables the storage and release of mechanical strain energy, allowing for energy conservation that can be seen here, which is very important for the economy of locomotion, but also in tasks of power amplification and attenuation by the muscle, for example, in jumpings and landings. The energy exchange within the muscle tendon unit further enables favorable operating conditions for the muscle with regard to its force length and force velocity relationship. For example, in this figure here, the operating velocity of the muscle tendon unit and the muscle belly during the stance phase of running is illustrated. The difference between curves arise from the decoupling by tendon stretch and shortening, allowing to operate the muscle belly at more favorable lower velocities. Moreover, the capacities of the muscle tendon unit, that means the maximal strength of the muscle and also the stiffness of the tendon, are important for movement performance. For example, it has been shown that sprinters feature a higher tendon force, so a higher muscular strength and a higher stiffness. Moreover, higher capacities of the triceps surae muscle tendon unit seems to be important for running economy, and higher capacities of the knee extensor muscle tendon unit for stability performance. It is now very well accepted that tendons, like muscle, indeed can adapt to increased loading. Two mechanisms of adaptation to increased loading can be identified. The first is an increase in the tendon cross-sectional area, so a hypertrophy of the tendon. And the second would be changes in the material properties, for example, an increase in collagen content or collagen cross-linking. Changes in the material or morphological properties would increase the resistance of the tissue, so increasing the stiffness. What happens on the cellular basis is that mechanical loading is transmitted via the extracellular matrix to the cytoskeleton of the mechanosensitive tendon cells, initiating expression of genes and growth factors responsible for catabolic and or anabolic cellular and molecular responses, for example, collagen synthesis. Okay, tendons are important, their capacities are correlated with performance. So how to train tendons effectively? The stimulus is the external strain that is applied via muscle forces. Here you can see an ultrasound video of the tendon and muscle of the triceps surae muscle tendon unit in a sequence of loading-unloading cycles. The displacement here of the muscle tendon unit junction during the contraction is indicative for the elongation, for the strain of the tendon. From a mechanobiological point of view, four mean parameters of the mechanical strain stimulus can be distinguished. This is the strain magnitude, strain frequency, strain rate, and strain duration. In a series of experiments, we modulated now those loading factors to better understand tendon adaptation. During each of the studies, we trained participants for 14 weeks, 4 times a week, with isometric plantar flexion contractions, while the loading volume was kept similar between protocols by adjusting the number of repetitions. The graphs now show the different loading protocols that were applied during the training. In the first experiment, we compared the effect of high loading with levels of around 6% tendon strain controlled by contraction intensities of 90% of the maximum voluntary contraction strength to a low protocol with around 3% strain controlled by contraction intensities of around 50% of the maximum. Our results showed adaptive responses only when trained at a high strain magnitude, so high loading. So small technical break. Slide is not going further, just a second. Okay, sorry. Okay. This was confirmed when training also featured a higher cycle frequency. Again, only the high loading protocol induced adaptive responses. Comparing explicitly different strain frequencies, so 1.17 Hertz versus a high frequency using 0.5 Hertz in cycles of either 3 seconds load or unloading, compared to 1 second loading, 1 second relaxation cycles, we found greater adaptive responses with low frequency compared to high frequency. In the following experiment, we modulated now the rate of strain application, and we compared the most effective protocol here with low rate to a jumping protocol with high strain rate, so the time in which the maximum force is applied. The results showed stronger effects at the protocol that featured a lower strain rate. I'm sorry again, the PowerPoint struggles. Sorry for that. Okay, we start here again. The results showed stronger effects at the protocol that featured the low strain rate. Finally, when comparing different loading durations of 12 seconds versus 3 seconds versus 1 second loading durations, the protocol that featured the 3 seconds loading elicited the greatest adaptive responses. Based on our findings, we can conclude that cyclic loading at a high strain magnitude and a duration of around 3 seconds is most effective for tendon adaptation. The reason for this is that the high strain magnitude may stress fibroblasts more and also a higher number of cells than with lower strains, and thus induce greater tissue responses, which is an agreement to in vitro studies. Moreover, because tendons feature viscoelastic properties, a certain time of load application of around 3 seconds seems necessary to transmit the strain to the cells. And for that reason, the shorter durations were not as effective. Yet longer durations did not have an additional effect in comparison to the 3 second cyclic loading, indicating that a 3 second duration was sufficient for strain transmission. Therefore, we can conclude that an effective training for tendons is characterized by a high loading, high intensity muscle contractions that induce high levels of strain. It should be applied cyclically, so repetitions of loading and unloading cycles, and our stimulus here with 5 sets, each containing 4 repetitions was very effective over the time of 3 months. It is very easy to implement, so the training took 10 to 15 minutes, so it can be very easily applied. When using static contraction as we did, an optimal joint angle should be chosen to account for a high force generation, so in the knee around 60 degrees and in the ankle joint 5-degree dorsiflexion. For any practical advice, I would like to refer the interested reader to our guidelines and that we made freely available on our homepage. In the next part of my talk, I want to introduce the concept of imbalances of muscle and tendon adaptation to be considered for tendon health. Most of the time, an increase in muscle strength due to training will be accompanied by an increase in tendon stiffness that can be seen as a protective mechanism to maintain physiological levels of strength. However, the development within a training period with changes in loading profile is not necessarily balanced. First, the temporal adaptation dynamics of both tissues are different, with slower response rates of the tendon due to a lower tissue turnover. And secondly, the mechanical stimuli to elicit adaptation of muscle and tendon are not the same. Resistance training with moderate intensities and plyometric training, so a lot of jumpings, show significant effects on muscle strength, but induce comparably small responses of the tendon. Accordingly, an imbalance between the force generated by the muscle and the resistance of the tissue may occur throughout the training, which means a greater and even non-physiological mechanical demand for the tissue, increasing the risk of injury. Such imbalances may contribute to the high prevalence of tendinopathy that can be found in athletes, particularly from jumping and power disciplines like handball, volleyball, basketball, and athletics. To prove our hypothesis of imbalances, we measured in mid-adolescent risk group volleyball athletes and untrained controls muscle and tendon properties every 3 months over 1 year. This figure shows the patellar tendon strain during maximum contractions with the average values for the athletes here in white and for the controls here on the right side, the average in black. The gray symbols indicate the individual data, and it is notable that not only the average strain here is higher in the athletes compared to the controls, but we can also see some substantial fluctuations of strain over the year. When we quantify these fluctuations as residuals, we can see significant differences in the athletes compared to the controls, so greater fluctuations in strain in the athletes. The reason for these fluctuations of strain were larger fluctuations of strength and a lower uniformity of changes in force and stiffness in the athletes. So we can conclude from this that a non-uniform development of muscle strength and tendon stiffness may exist in athletes with high levels of chronic strain and periods of marked increases in strength. However, it is unclear from these studies if imbalances in the muscle tendon development might be a sport-specific phenomenon in volleyball, and also the long-term development over adolescence is yet unclear. So we conducted 2 more studies, including now pre-adolescents, early adolescents, late adolescents, and young adults from diverse sports were present in all age groups, but particularly in the athletes. Furthermore, we were able to show that the frequency of high-level strains increased with age. So we can conclude evidence for a non-uniform development of muscle strength and tendon stiffness, with periods of marked increases of the mechanical demand for the tendon. Imbalances affect the general athletic population as well, and the frequency of high-level strain seems to increase with age and activity level, and why high level of strain being an indicator for a higher risk of tendon overuse injury. Now, given the evidence of imbalances as a potential risk factor for tendinopathy, it is straightforward that we were interested to use our evidence-based training for tendons as a prevention strategy to improve imbalances and tendon health in athletes of risk groups. In a first very recent study, we implemented a functional tendon training to the regular training of risk group handball players twice a week and measured tendon and muscle properties over 1 year again in 3 months intervals, as well as pain prevalence by the VISA-P score. For the pain prevalence, we found quantitatively and clinically relevant worsening only in the control group over the time course of the intervention, but none of the intervention athletes get worse. Therefore, functional tendon training can reduce the prevalence of patellar tendon pain. However, since we found no changes in the patellar tendon properties over the year, the application only twice a week was potentially not sufficient for tendon adaptation. Okay, for that reason, we conducted a second study recently. We again integrated tendon training to the regular training of basketball players, but now for 3 times a week. And again, we measured pain prevalence, tendon muscle properties over the course of 9 months. We were able to confirm that a specific muscle tendon training can improve pain prevalence. The frequency of participants in the control group that get quantitatively worse were higher as in the intervention group, and maybe more importantly, the frequency of athletes that improved here was higher in the intervention athletes than in the controls. This finding was accompanied by a reduction of high-level strains only in the intervention group, while it even increased in the controls, which was a result of an increase in the tendon stiffness found only in the intervention group. Therefore, we can conclude that tendon training can indeed reduce high levels of strain and pain prevalence, suggesting tendon training as an opportunity for tendinopathy prevention. To sum up, our first findings regarding the prevention effect of tendon training indicate that indeed tendon training has the potential to reduce pain prevalence and high level of tendon strain as a factor for tendon overuse injury. The easy implementation into regular trainings makes this evidence-based tendon training a very promising opportunity for tendon injury prevention in high-risk sports. In the last minutes, I want to make now an argument for the need of an individualized muscle tendon assessment, particularly for the prevention of tendon injury. We argued that the maximum tendon strain during a maximum contraction is a biological marker for the tissue demand. Therefore, if strain is too high, then the stiffness is too low for a given muscle strength, indicating an imbalance of muscle and tendon capacities. Wang and colleagues showed that cyclic strains of 9% act degenerative on the tendon structure and weaken its structure and degree. The study also provides evidence that too low deformations induce catabolic signaling in the tissue. Together with our own data, we can now derive rough thresholds of maximum strain for the identification of individuals showing imbalanced muscle and tendon capacities. Specifically, muscle strain value, maximum tendon strain values of more than 9% would consequently indicate a training for the tendon, while strain values lower than 4.5% would indicate a training for the muscle. In this graph now shows the maximum strain values of the Achilles tendon and patella tendon from a large number of individuals from diverse sports. We can indeed identify individuals with high-level strains where a training for the tendon would be indicated to overcome these imbalances. Also, some few individuals show very low strain values where a training of the muscle strength would be indicated. Such a diagnostic assessment may use ultrasound to measure the maximum tendon strain and dynamometry for the muscle strength assessment during a maximum contraction. Accordingly, we would be able to analyze the strain data and the strength data and to evaluate the individual balance of muscle and tendon capacities in order to determine the injury risk. Moreover, these values could be used for individualizing exercise prescriptions. Until now, the training load for the tendon is set with regard to the contraction intensity of the muscle to 90% of the maximum. While we think now it might be promising to determine the actual demand of the tendon. That means that when maximum strain is very high, say higher than 9%, a lower contraction intensity than 90% might be sufficient during the training to meet the effective strain ranges for tendon adaptation of 4.5 to 6.5%. With that, I hope that I was able to convince you that tendons are crucial for the performance of the muscle tendon unit. Furthermore, that there is a benefit to strengthen the tendon and that tendons can be trained effectively by our evidence-based protocol, which is very easy to apply. Such a training may ensure a balanced adaptation of muscle and tendon to prevent tendon overload injuries. And in future, an individualized muscle tendon assessment may improve the monitoring of a healthy muscle tendon unit development during structured training. With this, I would like to acknowledge the contribution of all the collaborators from our group and of course by the chair, Professor Adamantios Arampatzis. For further information, please refer to our homepage. Thanks again to the organizers and board, and thank you for your attention.
Terrific, Sebastian. Thank you so much. I knew some of the data because Professor Arampatzis reported about your studies as a keynote speaker at our last Fascia Research Congress in Berlin. That's where your department is working. But you went much further now in that short time. Now you even suggested a diagnostic procedure to determine at what for which athletes tendon training may be more important and for which muscular training may be more important. I'm very enthusiastic also because often we hear a specific fascia or tendon training is not necessary. If you do proper muscle training or cardiovascular training, then the fascia will adapt. But you have shown very clearly, no. In some of them, you need to focus on fascia, including tendons, and in others, it's not so important. I have one question that I always wanted to ask. All of you ultrasound researchers are focusing on the Achilles tendon and the patellar tendon because that's where your ultrasound works so well. And I'm very convinced now that we have the tendon adaptation as you reported. But how much can we trust that that also applies for a javelin thrower and a swimmer who are using their upper body? Do you have any indication that you can extrapolate to that?
Yeah, thanks, Robert. That's a good question. Actually, it's true. We are mainly focusing on the lower extremities. However, the biological basis for adaptation is very, very likely the same for all the tendons in the body. So we can be very sure to be able to extrapolate the basic mechanisms of adaptation also to the upper extremities, so tendons, for example, in the shoulder as well.
Okay, great. Yeah. And another question is that your protocol seems to work very reliable with the 3 seconds of static isometric contraction, but how can we implement that into dynamic movement in a class, in an exercise environment when you don't have these machines? Any suggestion?
Yeah, very good question. Yeah, indeed, because we wanted to apply a very controlled, standardized stimulus, we use these isometric contractions. Of course, in the field and in the regular training, we would also need to use other exercises. And I mentioned our recommendations for practitioners that can be downloaded on our website. And there we try to merge a lot of exercise examples, including also more dynamic exercises. Maybe as a general comment, when the main mechanisms that we identify in tendon adaptation are ensured, then also, of course, dynamic exercises are very feasible. This would include, however, high intensities by high intensity muscle contractions, so high loads. And when we need to consider about a certain duration of 3 seconds, this would mean that when we do a dynamic movement, we should pass the optimal joint angles at a certain level of duration. So the dynamic movement should be very, very slow. And in this case, so slow movement, high intensity, we are pretty sure that these exercises would be effective as well. And for example, in the studies that I presented on the prevention, we used, for example, these very practical dynamic exercises as well. So where we found an adaptation of the patellar tendon. So yes, we are convinced that these more functional exercises are effective.
And you mentioned you have these examples on your website now. I hadn't seen them. I only know the Berlin tendon training is described there. But now it's also on your department's website.
It's on the website, freely available. And in the end, we make some examples how training could look like. And we hope in the future, we will upload from time to time to add more and more experience.
And finally, if I can have one more question, because it just came up here on the chat box, you focused on prevention of injury, which is perfect. But when you have injury already and you are working as a rehab physiotherapist, any advice how you can stimulate the tendon to repair better?
Yeah, this is a good question. It's also a little bit a difficult question. However, there is some evidence now in the field that shows that indeed a high loading of the tendon is also very effective in the rehabilitation as well. So the Copenhagen group showed these some years ago already. And in the past years, we conducted a study as well, where we applied here the same tendon training, and we have very promising preliminary results showing that we can induce tendon adaptation also in tendinopathic tendons, where also the pain prevalence and the functional response greatly improved.
Wow, that's very relevant and very exciting, because most of the sports injuries are happening at tendinous tissues.
Yeah, that's true.
Yeah. So I would have hundreds of more questions, but our time is over, unfortunately. But if you continue to do research with that speed, I know if we interview you in 1.5 years again, you will have made again the same big jump as you did since the last time. Thank you so much.
We would love to contribute next time as well. Robert, thanks again for your invitation.
Thank you.
So, and now it's a pleasure for me to introduce the last but not the least professor that will talk about something that I really consider really interesting. So let me say bye, Mette Hansen, welcome. How are you?
I'm fine, thank you.
Mette Hansen is a professor, associated professor at the Public Health Department at Aarhus University, Denmark. So today she will talk about an interesting aspect. So she will talk about the influence of hormones in training, the strength muscle, and the influence of the hormones cycle on injury risk, especially about the knee injuries. So is that correct?
That is correct. Thank you, Anna.
So I'm really curious about it, because I consider that this aspect is not well incorporated in the training, especially with young women or women that are going to the menopausal time of their life. So I think that would be really an amazing presentation. So
thank you, Anna, for the nice presentation. And I also would like to thank your organizers for inviting me to do this presentation. That is my priority research area, so I'm very happy to present some results today within this area. When it comes to the menstrual cycle, the interest has been increasing the last decades, both from the athletes, but also in the research. And therefore, I think it's very important we go into, is there actually a direct link between the fluctuation in the female hormones during the menstrual cycle and both performance, but also in perspective to injury risk. When it comes to performance, that if the hormones have an effect, and we will say just 1% or less, it will be of great importance for the elite athletes, because here we know that 1% can be the difference between winning or not. And also for the athletes, it's very important to stay injury-free. So therefore, we also have to look into this aspect and spread the knowledge if there is a direct effect between the hormonal fluctuations and the risk of injuries. So today we'll focus on the menstrual cycle, and just to make a short summary, you can see how the estrogen is going up and is peaking halfway through the menstrual cycle, just before ovulation. Then it goes down and it stays high at a quite high level during the rest of the menstrual cycle until the bleeding period start again. For the progesterone, it stayed low until halfway through the menstrual cycle, and then after ovulation it is increasing and stay high the rest of the menstrual cycle until the start of the bleeding period. So it is these hormonal fluctuations we'll focus on today. And the question I would like to ask is, does the hormonal fluctuation, or do the hormonal fluctuation during the menstrual cycle influence tendon and ligament laxity, and thereby ligament injury risk? And furthermore, do the hormonal fluctuation influence strength and power performance? If you go to the media, you will find that the research seems to be lagging behind in relation to giving the answer on these questions. Many athletes and sports teams have already started tracking the athlete's menstrual cycle, and there are several apps developed to perform this kind of tracking of the female athletes. Still, I find it relevant to ask the question, is there actually any solid evidence that show that it's worth doing this tracking of the menstrual cycle? So we will start by focus on the injury risk. Okay, tendon and ligaments has a similar structure in many ways. They are both very rich in type 1 collagen. Nevertheless, if there is a systemic effect of the hormones on these tissues, the consequences of this may differ between tendon and ligaments, I will postulate. At first, for the ligaments, it has been shown there is a direct positive relationship between laxity and ligament rupture. So a stiffer tendon is a stiffer ligament is what you should go for if you want to prevent ligament injuries. Also, you might like to go for a stiff tendon, because a stiff tendon may transmit the force produced by the connective muscle to the bone faster. Said in another way, a stiff tendon may improve power performance. Nevertheless, a stiff tendon may become too stiff and enhance the risk of sustaining a tendon overload injury and a muscle injury due to the eccentric load on the muscle during muscle contraction is enhanced due to the attached stiff tendon is not lengthening as much as if you have had a compliant tendon. With this background, I will turn back to the influence of sex and sex hormone on injury risk. At first, by comparing men and women, you have a very diverse sex hormonal profile. It is documented that the risk of sustaining an ACL injury is markedly higher in young women than in men. But when it comes to tendon injuries, young women seem to protect it. They have a lower risk of injury compared to men. Another interesting observation is that, which may be coupled to a more compliant tendon, is that young women also seem to be in a lower risk of experiencing a muscle strain injury related to a more compliant tendon. So with this observation should fit with the previous slide, you'll expect that tendon and ligament stiffness is lower in women and in men. And actually there's some support for this. Bjarke Haraldsen performed his PhD at Institute of Sports Medicine, the same place as I, and he tested tendon fascicles. And what he observed was that the ultimate stress before rupture was much higher for the fascicles from men compared to the fascicle from women, indicating a structural difference. Furthermore, Unambele, you can see here to the right, and his co-authors have reported that the relative stiffness during a maximal voluntary isometric contraction was lower in women than in men. These cross-sectional data seems to indicate that sex matters when we are discussing tendon and ligament biomechanical properties. But is there a reason to believe that the female hormones, the estrogen, influence the structure of tendon and ligament and thereby the biomechanical properties and the stability of the joint? And the first thing here is that receptors have been localized within the human ACL and in the tendon tissue, and this suggests there should be an effect. In a cross-sectional study, we recruited very well-trained female handball players and tested the patellar tendon biomechanical properties doing a maximal isometric contraction. And in the non-use of oral contraceptive, we observed a negative correlation between the concentration of estrogen in the blood on the day of testing and the patellar tendon stiffness. So a high concentration of estrogen was associated with a lower tendon stiffness across this population of handball players. This is only a cross-sectional data you see here, where each movement only were measured once. So it is actually amazing that we can see an association. But what if the same women are measured several times during the menstrual cycle? Will the biomechanical properties and joint stability vary? Based on the previous observation, we would expect that the biomechanical properties of the ligament would be impaired when the estrogen is peaking in the late follicular phase just before ovulation. One of the most comprehensive and well-designed studies which had tested for differences in knee laxity during the menstrual cycle is this study by Lee and College. They tested 7 times during the menstrual cycle, and at the same time they obtained blood samples to confirm the menstrual phases. The results shown, as you can see here by the star, they indicated that the knee laxity was greater around ovulation, where the level of estrogen was peaking. As mentioned in the beginning of the speech, there is a direct positive relationship between laxity and ligament rupture. Therefore, based on these results shown in this slide, it would be expected that the risk of sustaining an ACL injury would be higher in the late part of the follicular phase, just around ovulation, where the estrogen is peaking. And there have been performed a review related to this area, and here you can see that actually there's several case studies which suggest that the ACL injury risk is higher in the follicular phase of the menstrual cycle, especially in the late part of the follicular phase. In contrast, when the progesterone level is enhanced at the same time as the estrogen in the luteal phase, the risk of sustaining an injury is at the lowest level. And here you can actually see one of the case studies, and you can see the cases marked by these crosses. And you can see how the number of cases is peaking when the estrogen is peaking. Whereas when the progesterone is high, the number of cases goes down. But what is actually going on? How is the structure influenced by the estrogen? Is there a variation in the laxity and the injury? Or is it due to changes in the collagen fiber density, the diameter, or the orientation? Or is it the cross-linking between the collagen molecules which make the tissue more stiff, which are influenced by the estrogen? In Keith Barth group, Lee and his co-authors here had tested engineered ligaments which were exposed to physiological high concentration of estrogen for 24 or 48 hours. They did not observe any difference during this short time period in the collagen content, but when they tested the biomechanical properties of the engineered ligament, then you could see how the there was an impairment in the biomechanical properties when the engineered ligament had been exposed to high level of estrogen for 48 hours. But how can we then explain these differences, this decline in biomechanical properties? Since they could not see any change in the collagen content, and went further and tested the activity of the enzyme which introduced these enzymatic crosslinks between the collagen molecules. The results showed that it was a very clever idea, because what they observed was that when the engineered ligament had been exposed for high level of estrogen for 48 hours, this enzyme was, the activity of this enzyme was markedly reduced. Therefore, it can be proposed that the reason for the reduction in biomechanical properties when estrogen exposure is high is related to this decline in this enzyme activity, and thereby there is a reduction in the of these crosslinks within the tissue, which should otherwise strengthen the tissue. Another hormone which may explain why some girls are in higher risk of sustaining an ACL injury is this hormone relaxin. Relaxin receptor have also been identified in the female ACL tissue. And in animals, they have found that the load to failure of ACL ligament was significantly reduced after administration of relaxin for 3 weeks, suggesting a link between this hormone and the biomechanical properties. And in line with this negative impact of relaxin, a prospective study with elite athletes reported that girls who had a level of relaxin above 6 picogram per milliliter were 4 times more likely to sustain an ACL tear during a 4-year period. So should we sum up when it comes to a profile indicating a higher risk of sustaining an ACL injury, a knee injury? There we have to conclude that women are in a 2 to 8 times higher risk compared to men. Also, when we compare woman to woman, a high estrogen level, which is you see in general or acutely during the menstrual cycle just before ovulation, this situation is associated with a higher knee laxity. And this higher knee laxity is also, you also find that at this time point, when the estrogen-progesterone ratio is peaking, there seems to be a higher risk of sustaining an ACL rupture. And furthermore, if you have a high relaxin level, it is also associated with a higher risk of sustaining an ACL rupture. So can we do anything to minimize the risk of sustaining a knee injury? And actually there is 2 huge case studies. You can see they have included several thousands of women. And here they observed in both these studies that the risk of sustaining an ACL rupture seems to be 20% reduced in users of oral contraceptives compared to non-users. Another thing we should focus on when we are talking about reducing the risk of sustaining an ACL injury is use of oral contraceptives. If you use oral contraceptives, you inhibit the endogenous secretion of estrogen and progesterone. So therefore, the level is very low of these endogenous hormones. But then on daily basis, you ingest the oral contraceptive pill and you have this small rise on daily basis in this hormone. But you should focus on there's no peak in estrogen. Furthermore, the level of estrogen is lower in oral contraceptive users in general when we are summarizing both the concentration of the endogenous and exogenous amount of estrogen. Another hormonal effect which is you see in oral contraceptive users is that the level of IGF-1 is lower in oral contraceptive users, And when we, in a previous study, injected IGF-1 directly into the patellar tendon and a saline in the other tendon, then we observed that the tendon collagen synthesis rate was markedly enhanced, significantly enhanced in the patellar tendon tissue which had been exposed to IGF-1. Therefore, when the IGF-1 level is low in oral contraceptive users, it will suggest that also the tendon collagen synthesis is lower. Since we cannot observe that the size of the tendon is changed between users and non-users of oral contraceptive users when you have this cross-sectional data, then we will suggest that the general turnover of collagen is lower in oral contraceptive users compared to non-users. And when the turnover is lower, it will also mean that when it's lower, then you have time for introducing these crosslinks and make the tendon more stiff. So there is there's both this lower level of estrogen, no peak in estrogen as seen in non-users, and also this lower level of IGF-1, which suggests that the use of oral contraceptives may be associated with a lower tendon collagen turnover in general, a higher tendon and ligament stiffness, and a reduced risk of sustaining ACL injury, as suggested by the case studies. So we actually measured the tendon collagen synthesis rate in oral contraceptive users and non-users, and here we observed that the synthesis rate was lower in the patellar tendon compared in the users of oral contraceptives compared to the controls. And the others, we have looked into variation in knee laxity during the menstrual cycle and also during the pill cycle. And here you can see that by the blue is the non-users, and you can see laxity goes up around ovulation, whereas in the OC users, the laxity was in general lower and there were no fluctuations. Not all studies have seen that the laxity is lower in users of oral contraceptives compared to non-users, but I have to indicate the number of participants in these studies are quite low. And this is the far greatest study within this area where they have seen this effect, and they have measured several times during the cycle. So use of oral contraceptives seems to be positive in relation to the risk of sustaining an ACL injury. But on the other hand, there may also be drawbacks by having a stiff tendon. Because if you have a stiff tendon, as I suggested in the beginning of the talk, then the load on the muscle tissue may be greater during locomotion. And they measured on a marker in this study, creatine kinase. It was a very tough protocol where they have 240 eccentric leg contractions. And here you can see that the level of this marker for muscle damage was higher in the oral contraceptive users compared to the non-users. And also the decline in strength, it was similar after 24 hours, but it went further down in the users of oral contraceptive users and the men, which were not observed in the non-users of oral contraceptives. You can also see, this is another study where they look at strength recovery after 50 eccentric maximal contraction, and here you can see how the non-users of oral contraceptives went up faster compared to the oral contraceptive users. So you may reduce your risk of ACL injury if you use oral contraceptives, but you also may enhance your risk of sustaining it for more muscle damage and delayed recovery. And in perspective too, you have now the European Championship in handball is going to start very soon. So they may protect themselves by using oral contraceptives, but if they go the whole way to the final, then the risk of being more sore when you come to the final will be greater in the oral contraceptive users. So in that way, it may impair the performance. So there's really pros and cons relating to users or contraceptives. Yes, so that was part, but what if you do not want to use oral contraceptives due to drawbacks? There's also some mental thing when it comes, there could be drawbacks when you're using oral contraceptives. What can you then do? We are right now looking at data from a huge study where we have included 400 Danish top class female soccer players, and we have followed them for 1 year. And in this study, we have introduced 4 exercises which actually seems to prevent the risk of having a knee injury. And now you'll see, we have asked them by an SMS each week if they have done the exercises. And now we'll look into is if the risk of having a knee injury is greater in the one who have not performed the exercise compared to the one who have performed the exercise. We have also asked them where they are in the cycle if they sustain an injury. So we will also try to look into if we can actually detect a difference in the injury risk related to the menstrual cycle. Yes. So in summary, does the hormone fluctuation during the menstrual cycle influence the tendon ligament laxity? Yes, I will say. Or at least there seems to be an association between a high estrogen-progesterone ratio and knee joint laxity. I have to say, I have only focused on the knee and not in general. And when it comes to the injury risk, yes, there seems to be a higher risk of sustaining an ACL injury in the time period just around ovulation where the estrogen is peaking. But what about strength and power performance? We can approach it by 2 ways. We can look from the negative side, is there some part of the menstrual cycle where the performance is impaired, or we could go with the positive attitudes and see is there some period of the menstrual cycle where the performance is improved. And when it comes to menstrual cycle, what many young women notice is they have some pain or some symptoms just just before the bleeding period is starting and in the beginning of the bleeding period. And this is also true when it comes to elite athletes. We have sent out questionnaires to all the female elite athletes in Denmark, which are associated with the organization called Team Denmark. And there's 400 of them, and we got feedback from almost 200. And we were asking them for symptoms. And now we go with the negative attitude. And here you can see that a huge percentage of them noticed negative symptoms, bloating, tiredness, stomach pain, well, all these things related to the menstrual cycle. And they reported this they experienced this 1 to 3 days before the bleeding period and the first 1 to 3 days after start of the bleeding period. And also mentally, you can see many of them, half of them reported mood swings, which can also impair performance. And what we also noticed in this questionnaire was 13 of the Danish elite athletes reported that these negative symptoms sometimes or always caused them not to participate in or complete the training schedule. So it's very important that the trainer, the coaches actually know that there is this, because otherwise they'll think that the athletes are not motivated if they're not coming to the training. But here it's very important that they actually know that it is due to pain, it is due to these negative symptoms. So this report suggests that there could be some impairment just around the beginning of the menstrual cycle when it comes to performance. But we have no data on performance related to this, I have to say. It was just a questionnaire. We could also go with the positive attitudes. And here's the data on postmenopausal women, which suggests that hormonal therapy improve maintenance of muscle strength. So that will suggest that it is positive. Estrogen, a high level of estrogen is positive. And there are also some animal data where they have tested ovariatomized mice and rats. And here they observed that the mucin function, very important for the muscle contraction, seems to be impaired where the estrogen is reduced markedly by the ovariatomation, but it is enhanced again when they add back the estrogen, suggesting that estrogen have a positive effect on the mucin function and thereby the muscle strength. But when we asked for positive symptoms related to the menstrual cycle, there were not many of them which reported, who reported there was some part of the menstrual cycle where they have some positive effect. And you can see for the physical symptoms, 11% reported that they feel stronger in some part of the menstrual cycle, but we could not, based on the data, say that it was some specific phase of the menstrual cycle. And when it comes to the emotional symptoms, there was, you can see there was only 2 of the 79 women who felt that they were more happy during some part of the menstrual cycle. And again, we couldn't, it's only based on 2 cases, but we couldn't relate it to any specific cycle. So it seems that they are more focused on the negative side of the menstrual cycle. Okay, but then we can say, what about then about performance? And there is there was this study where they look into the hand grip strength and finger strength. And in this study, they reported that the performance in these tests was better in the middle part of the menstrual cycle. But I have to say there were no blood analysis. Therefore, they didn't have any confirmation of where the girls were during the menstrual cycle. And you can see here the data, you can see here you have around the ovulation, and you can see how the hand grip strength were markedly higher, almost, you can see 50%. So that's really something you will notice, I think, if you had a 50% increase in your strength performance. There's also there's some small study where they also have looked into the difference in strength performance. But, and here they have also, it's suggested that when the estrogen is high around the mid part of the menstrual cycle, the strength performance was higher. But again, they didn't confirm the menstrual cycle in all the participants, or not at all. So therefore, I also went into the literature and made a search for all the studies which are there. And here the general picture is, I don't know if you can see the top line, but you can see here when they have tested during the menstrual cycle, they have only tested a few times, 2 or 3 times, most of them. You can also see that the number of participants in these studies is quite low. And therefore it's not surprised that they don't see anything, no variation in strength performance. So we didn't felt that there were enough evidence based on high quality studies when it comes to answering the question, is there a difference in strength performance during the menstrual cycle? And therefore, right now, my PhD student is doing the final analysis based on a study where we have had 40 young women coming into us 7 or 9 times during a menstrual cycle. And when we are testing the performance, you can see these tests we are performing. We also collect blood samples to confirm the menstrual cycle, where the phase of the menstrual cycle, and also they do ovulation kit test to catch the time point where the they have the ovulation. And we also do habituation to these tests 3 times. So really now try to get results where we can have more evidence for if there is actually a difference in strength performance during the menstrual cycle. And hopefully these data will be published in the spring. So for the last question is, do the hormonal fluctuation during the menstrual cycle influence strength and power performance? I will say right until now, it is not clear. There is a need for these high quality studies, but maybe there is a minor impairment in performance in the menses phase where they have all these negative symptoms of the menstrual cycle. And maybe if you go with the positive side, there may be an enhanced strength performance in the late phase of the follicular phase. But the studies which are suggesting this have not confirmed the time point in the menstrual cycle by blood analysis. Yes, this was the end of the talk. I will end up by thanking a lot of people. And I especially want to highlight my supervisor doing my PhD, Michael Kerr from Institute of Sports Medicine, who was the person who introduced me to this research area. And also I would like to send a thank to my research group in Aarhus, who is right now performing all the hard work related to these studies. There is Tine, who is doing the menstrual cycle study. And she has also done a study where she looked into the effect of transdermal estrogen therapy to postmenopausal women. And these data is submitted, so they will also soon be out there. Then there's Mikkel, who he started his PhD in September. And today, right now, he is testing the effect of oral contraceptives, using or not using, related to strength recovery. The data I showed you suggesting that oral contraceptives impair your recovery and enhance muscle damage was based on untrained athletes, but he includes very well-trained women when he's performing his test. And then finally, there's my postdoc, Line, who is doing cell work to see if there's if the estrogen, progesterone, and all the different kind of synthetic hormones in the oral contraceptive influence muscle protein turnover in muscle cells. And she's also part of all the other studies. Yes. Good. And finally, I would like to thank you for listening, and I will be very happy to answer questions. Just send me a mail or contact me in other ways. Yes, thank you.
So, thank you, Matt. Very interesting. Yes, really. And I found I have many considerations. So, because obviously you were focused mostly on the young women athletes or people that are in the young phase of their life. But there's a big number of women around menopausal time or postmenopausal time of their life that they train and they do competition. So what's your suggestion? For example, also considering the opportunity to choose or not hormone replacement therapy. So what's your suggestion for this kind of woman?
Yeah, I really think if women are not designed to live for such a long time. And now the age where you go into menopause is around 51, 52. So the women today live more than 1/3 of their life as postmenopausal women. And when you're postmenopausal, the estrogen level is very low. And sometimes we can not detect it by our analysis. And this has some consequences. We all know that it has negative consequences for the bone, but also there is data which show that the decline in muscle strength is accelerated when women turn into menopause. But if you use all estrogen replacement therapy, then the muscle strength stay up for a longer time. And you have also twin studying where you can see monozygotic twin studies where you have one twin using and other twin not using estrogen replacement therapy, and you can see that the one using estrogen therapy is performing better and have the body composition is also more beneficial, more muscle, less fat. So in that way, seems to be, and there's a meta-analysis also suggesting users of hormone replacement therapy is 5% stronger than non-users. So they all seems very, very positive, but of course we also have to focus on the overall pictures. And we know that we also have to be concerned about using estrogen replacement therapy and specifically hormone replacement therapy, where you also have the progesterone included. So therefore, we have started a new research where we have tested the positive effect of using estrogen replacement therapy, but now we also turn into alternatives. And we have just published this week a study where we have looked into a fermented red clover extract containing phytoestrogens.
Yeah.
And it is just a small pilot study. It's a crossover study. 10 postmenopausal women using this dietary supplement for 14 days. But when we took our blood muscle samples and looked for muscle signaling proteins, we observed that the marker for muscle breakdown, the FOXO1 and FOXO3, were lower after the period where they have used the red clover extract, including the phytoestrogen, compared to the placebo period where they have used a control supplement. Mm-hmm. And we now search for money to a more prolonged study to see if there could be any benefit. The reason for suggesting this compared to the estrogen replacement therapy is that these type of phytoestrogen seems to have a high affinity for the estrogen beta receptor, which are in the blood, which are in the bone and in the muscle, whereas the sensitivity for binding to the estrogen alpha receptor, you have in high concentration in the breast and in the ovaria, is very low. Yeah. So therefore we think that we can have the positive effects, but not the negative effects, by using estrogen. And you can also see in China and Thailand, everything where they eat a lot of phytoestrogens, the risk of having breast cancer is actually lower. Yeah. So therefore we think that it is a way to go. Yeah. To have the positive, to see if we can in some way combat with the otherwise decline in the muscle function and in bone and so on.
So that takes in a special focus the influence of nutrition in healthy young athletes. For example, I'm considering, for example, some young athletes, especially gymnasts, or I would say also dancer, that they don't eat too much. They have problem with anorexia. This might be a problem also for, not only for the bones, of course we know, but for example, because they exceed in training or they do too much. What's your opinion?
Yeah, but we really have to use the data we have for the postmenopausal women with low level of estrogen, but because that is what is characterizing these athletes. If you're not eating enough compared to what you need, you have a low energy availability, then the estrogen level goes down. You don't have a menstrual cycle running. And that is also what we see in the elite athletes questionnaire from Team Denmark. There is a huge fraction of the athletes who are not a normal menstrual cycle. Yeah. And here you should focus on the positive effect of estrogen as well. You say that you can think that if the estrogen is low, then the synthesis of collagen within the bone, but also within the ligaments and in the tendon is also going down. So your ability to recover if you have done any strength-related exercise is impaired. If the estrogen is low, I would suggest. And also your ability to adapt to the training would be reduced because you don't have the estrogen to help you. And also there's data suggesting that the estrogen actually seems to protect against damage of the muscle cellular membrane. So you may also thereby reduce your recovery. And there's data suggesting that if you not have a menstrual cycle running, your risk of sustaining overuse injury is also enhanced. But Mikkel, who is doing the World Contraceptive study right now, he also started up another study in February, where he will look into the consequence of training and at the same time reduce your intake of energy. And here we will measure if the muscle synthesis rate is lower in the ones who is randomized to not eat very much compared to the one who is eating an energy balance diet.
Yeah. So thank you, Matt. It was so interesting. I think we could talk for hours, but we have to cut. And so thank you so much for sharing your knowledge and stay with us. So I hope to see you soon in person.
In real life. Yes, thank you for the possibility to be here today.
Bye, Mette. Thank you so much.
Bye.
Just missed one. Hi, Laurie C. Good afternoon.
Good afternoon.
Yes. How is your day? And
so far, so good. How about you?
Thank you. Welcome to the Fashion Movement Sports.
Excellent.
Wonderful. Laurie C. is anatomy and a professor graduating Pilates, yoga, dances, and many things, as well as anatomy trainers profession. Is a movement fellow. And Laurie C., what you're surprising for us today, and what you need?
I'm doing on fascia and the dynamic body, especially looking at coordination and spatial use. And basically anybody is welcome in to play. I have a mat down. That's what we're going to be doing a little bit later, and a yoga block if you have it. Just keeping it simple, but playful as well.
Okay, so you will prepare. So today we have finished our day with the Laurie C, and prepare yourself. In a few minutes we will come back. You have just time to prepare your space for training yourself. So in a few minutes we will come back. Thank you. I'll see you in a few minutes.
Sounds.
Hi.
Hi, so I'm Lori Nemitz. We're getting onto our mats or your space really soon. First, I want to play a little bit for this fascia and the dynamic body, spatial use and coordination by bringing out a piece of string. And you may have played with strings as a kid. I sure did at some point. And here I'm going to show you, if I thread together my string, our spatial dynamic matters. So if I'm here versus flat against the ground, it's going to make a difference how I perceive the body and the fascia that surrounds the muscles. So again, this is a little bit of some of the studies that were done recently. We were looking again at the body flattened out with those collagen fibers instead of that spaciousness that we have and the dynamic quality those fibers can play with each other. So we're going to do a little bit of a practice today, playing with all of those qualities. It's something I enjoy from various parts of my work. You don't need much today. We're just going to maybe grab a yoga block, have a mat of some sort. You're welcome into this practice and play whatever your movement discipline. We're going to start out just slowly, simply getting hands, arms warmed up. So I'm going to show you my hands really large here against the screen. We're going to fold in a couple times, bring the elbow up, circle it around. And as you do that, you may notice every time that you're bringing the elbows up, your circles may be slightly different. This is good. We want to bring slightly different qualities to the fascia. Fascia, as we know, responds well to vectors, multi-directionality, but also responds well to differences in speed and timing. Loading matters. So let's maybe do this a little bit faster as we go, starting to get this coordination into play as well. One more time of doing this, and then we're going to change to a little finger exercise. So hands, take your thumb to your index finger, thumb to your fourth finger, and play with this for a moment. Just get that coordination again. Maybe speed it up, maybe slow it down as you're there. And then get thumb to your middle finger, thumb to your pinky. Coordinate this action. Again, speeding up, maybe slowing it down as your preference may be. One hand is going to now do thumb to index, thumb to fourth. Other hand, thumb to middle, thumb to pinky. Can you hold two different things in your body system? This is also for the brain as well. But fascially, this is making us kind of coordinate many, many different things at the same time. Let's switch that. So the other hand, thumb to index, thumb to fourth. Other hand, thumb to middle, thumb to pinky. And see if you can, again, get that action going. Don't worry if your brain is going, no. But these sorts of exercises really good for coordination and playing together, something we value again, in a myofascially efficient body. I do a lot of kayaking, I do a lot of movement, and I always want to go more time, longer, for less effort. And that's some of the efficiency we bring into the body. So let's get down onto the floor. And we're going to start off here, just with some little circles, simply. We're going to allow ourselves to come forwards, maybe with an inhale, maybe taking an exhale as you scoot back. Just playing with that, and again, changing the dynamics of the body system. A little faster, a little bit slower, and then switching around the other way. Our circles will never be exactly the same. That's great too for the body system. Let's play around a few more times. Circling in, and letting that come arm back into the center and settling. I'm going to just take off the layer, make it easier for you to see me. And we're going to come on to hands and knees and just take a few little cat-cows. Again, it doesn't matter if you practice yoga or not, or just arching, looking up at the eyes, up towards the ceiling or sky, rounding through the back of the body. And we typically do this inhaling, looking the eyes and head on up, exhaling, rounding through the back of the body. But play with that dynamic change. Maybe exhale as you bring the eyes up. Inhale as you round through the back of the body. and just notice the difference that may invite into the body system. Now let's make it a little bit more dynamic as well. Taking that arch and then pushing back into child's or shell pose. Taking that up and again, taking that back into that shell or child's pose one more time. And rounding back. Coming back onto hands and knees. Let's take ourselves tucking the toes under, sitting back on the heels for a moment. Hopefully you can see that. Interlacing hands, pressing the arms in front, lifting the arms up towards the ceiling, nodding the chin in towards the chest. Take a breath as you're there. Interlace the hands behind the back of the body. Get the opposite action to the foot for a moment. Either coming with the head down to the floor or rolling up onto the crown of the head. Let that go. Hands and knees again. Let's do a little cat twist. Traditionally, again, we're threading through. Right hand threads through. We're pushing out to the side. Let's take that 2 more times. Threading through. Pushing out to the side. 1 more time, threading through. Pushing out to the side, taking that hand down, taking the other side. Then threading through, pushing out to the side. Threading through, pushing out to the side. Threading through and pushing out to the side. Set that down. Now let's play here a little bit. Let's go to the high diagonal corner. Sweep it down by our knee and let that come on out. Let's take that again. High diagonal, sweep it down to the side. And then let's do it down towards our knee, sweep it up to the top edge of our mat. Down towards the knee, sweep it up towards the top edge of our mat. Set that side down. Same thing on the other side. Front of the hand, sweep it down by the knee. Front of the hand, sweep it down by the knee. And to our lower knee, sweep it up towards the upper corner. Down by the lower knee, sweep it up to the upper corner. Back to our cat-cows, but let's freeform for a moment. Let's round through the whole of the body and change a little bit of that dynamic as we need to go. So now we're going to do something I like to call river jumps. We're going to pretend our mat is a river we need to jump over with our feet side to side. So now we're adding a little bit of loading to the body system. And again, we can play with dynamics here. Hands are going to plant down onto the mat, and we'll bring our legs off to the side. And again, our goal here is to jump up and over the mat. Again, we're coordinating middle of the body with the outer sides of the body as we're here. And maybe we start to go faster. And come on back into the center. Can we do this slowing down and coming back into the center? Come on back, hands and knees again. Once again, sit back on the heels, interlace the hands, press them up above you, lift up and above, let that relax, release. Let's play with a little more coordination in something that looks kind of like downward facing dog. Doesn't matter if that's part of your normal repertoire. We're going to push back and take ourselves into that position, bending the knees, sending the hips and buttocks back behind you. Again, if you are tight, you may have to keep the knees a little bit bent here. That's okay. We're going to take the right hand off the floor, press it underneath to the left leg or the left foot. Let that go. Take the other side, pressing the hand, the other side, and again, left to the right leg, right foot, wherever that is. Again, we're making it into a 3-legged down dog. Set that down, let that relax, release, sit back on your heels. We're going to add to that. So we're going to, again, make the coordination a little more challenging. If it's hard for you, again, think it. And we'll try to work into this slowly, gently. So again, hands and knees. Pressing back, downward facing dog. Picking up, right hand up off the floor to the left leg or left ankle. And taking the right foot any amount off the floor. Do the best you can here. Set that down. Other side.
Left hand off the floor to the right leg, right foot. And set the left leg sending up in the air, coordinating that action into the body system. Let that go. Let that relax, release. Walk hands to feet, feet towards hands. And just pause for a moment here. Rolling yourself up, thinking of the front of the spine, lifting you up to stand. Great. So now grab that yoga block, that yoga book, whatever it is you have handy nearby. It can be a book, block. Set it down on the floor. And we're just first going to stand steady and tall. Bringing the arms up above, inhaling, lengthening up and over to one side, back into the center. Inhaling, exhaling over to the other side, back into the center. Drop the arms down. Drop one hand down to the side, back to center. Drop the other arm down to the side, back into the center, pausing. Now here's where we use that block. We're going to step on the block. We're going to pretend we have a second block right underneath our foot. Here again, we're challenging coordination in the body system, lifting the arms up above, coming up and over to one side, back into the center, and coming up and over to the other side. Back into the center. Whoa, if you fall off, that's okay. Take yourself back up and drop the arm down to the side. Back into the center. Drop the other arm down by the side. Back into the center. Same thing on the other side. I'm going to push this a little further back so we can see each other a little better as we're there. And again, same thing. Lifting up above. Taking it up and over to the side. Back into the center, up and over to the other side. Back into the center, dropping the arms, dropping down to the side, into the center, dropping over to the other side. Into the center, relaxing, releasing, coming off of that block. And let's take the block to the side and play a little bit with adding to all of this. So what we're going to do is an arm sequence. I learned a variation of about 30 years ago. Comes from the modern dance world, so many of you may have seen variations of this. I've added my own spin to this and have been teaching it for about 10 years in relationship to myofascia. So what we're going to do is first start with the arms swinging side to side and just taking that action. So what I'm doing here too, I'm preloading as well as using momentum to an advantage. Momentum isn't always a bad word, especially in terms of fascia. And let's take that same action on the other side. Swing, easiness, just notice the differences. And then bring it back to the side. So adding on, your first side, swing it over, and then bring it around and back. Halfway back up to the ceiling, and let that go. So other side, swing it across, around and back, halfway back up, pause, let it go. Let's do it again. Cross, around and back, halfway back up and pause, across, around and back, halfway back up and pause. All right, so now we're going to do a little bit more of the action of preloading the body system, especially in terms of jumping. You know, if I bend the knees and I stay down too long, I lose that fascial recoil, the elastic recoil that I can take that if I preload and come into an easy place of continuing something like a jump. We know from people like Dr. Schleip, this is highly trainable. We can increase this ability. So what we're going to do here is we're going to start that action first to bending the knees, and we'll take it into jumping in a little bit. So again, arm to the side, bending the knees, just pulse with the knees as we go. So across the body, around and back, halfway back up and pause. Across the body, around and back, halfway back up and pause. Across the body, halfway back, across, and let go. So let's now add the jump to this. So here we go. Every time we're going to preload and jump. So here it goes.
Arm out to the side, bending, jumping, and taking this back up and pausing. So across the body, halfway back, up and pause. Across, around and back, halfway back up and pause. Across, around and back, halfway back up and pause. So we've now started coordination. We're going to add even more spatial directionality to it. So I could start this walking, same pattern of the arms, taking it across, around and back, halfway back up and pause, and maybe take this walking all different directions at the same time. I'm starting to coordinate more things at the same time. We can take this jumping as well as we go. Change that directionality, change and make some little different movement as you go. All right, shake out from there and just allow yourself to organize the body system however that is for you through the center of the body, and just let the arms go out to the side. Easy, easy, almost like Tai Chi arms. A little bit of flapping out to the side, let the body settle, and then think of this motivating from your pelvis, kind of from the front. ASIS is shifting and turning. Again, does that change the directionality of where you place your attention, change the movement quality in the rest of your body? So again, if I shift from the front of my pelvis, that's going to feel a little bit different. I can vary again, speed. Maybe I like to go fast. Maybe I'm going to play a little bit with the slowness. Start to bring that down, down gently, slowly, gently. And we're going to come on down to the floor for a little final relaxation, tension, and release. So all the way down onto the floor. Allow the body to settle after all that practice, and take a moment before we take our final relaxation, just from your heels, doing a little bit of a heel rock through the entire body system. Bones are moving, but everything else, myofascial around it, is perhaps relaxing, releasing. Allow that to settle, and we're going to start with squeezing toes and feet quite tightly, deepening that breath, and then releasing. Again, squeezing toes, feet, legs, holding all of that quite tightly, deepening the breath, and releasing. Again, squeezing toes, feet, legs, front of the body, back of the body, through the arms even, into the fists of the hands, squeezing, holding, deepening the breath. Relax, release, let go. Again, squeezing toes, feet, legs, front of body, back of body, through the arms, into the fists of the hands, into the muscles of the face, squeezing, holding, deepening the breath, relaxing, releasing, letting that all go. Allow the body to settle deeply into the floor. And just take in a full deep inhale and a full deep exhalation. And wiggle fingers, toes, and just bring yourself any movement your body needs. Maybe it's a big deep yawn, reach above you. And then as you are ready, roll yourself to the side. Bring yourself up slowly, gently, comfortable seated position. This was a short little playful practice into some of the work that I'm doing. I'm currently writing a book for Handspring Publishing on, again, some of these concepts in myofascial movement. So thrilling to actually get to see some of you again in the virtual world, meet some of you new, and again, grateful for our time together. Thank you so much. Take care. Bye.